Good morning. This is the official welcome, and whether you're here in person or joining us virtually, we feel so wonderful to have you be a part of this conference. We started out feeling like the people who come here are indeed our kindred spirits, united in our commitment to transforming care and reducing preventable harm. This year, our focus is maternal health. We may not all be mothers or aspire to be mothers, but certainly everyone here was birthed from a mother. And so it's a universal concern, and yet it's also, we are in a kind of shocking and embarrassing situation that the US has the highest maternal mortality rates among high-income countries. And we just don't want to accept that as normal. I really want to thank the Board of Directors for supporting this as a topic for the Stoelting Conference this year. And also we want to thank our Program Steering Committee, who after many months of working together at very weird hours of the day, because we're all coming from different time zones, probably feel like we've finished some kind of gestational phase, and now we're about to have a baby. Okay, so we really encourage you to fully engage, not only with the programming that happens up here on the podium, but with conversations at your tables, during our social sessions in between, and definitely during our breakout session, where we feel like a lot of magic is going to happen when we put our heads and our hearts together. So the goal is for us to be here to sort of give ourselves permission to think differently, to collaborate across disciplines, across professions, with industry partners and patients as well. Our goal is not just incremental change, but we really want to push for transformational change. Over the next few days, I know most of you have looked at the agenda already, but we'll be looking closely at leading causes of severe maternal morbidity, explore innovative ways to reduce those. We'll shine a light on maternal health disparities and the steps that anesthesia clinicians can take to team with others to advance birth equity. We'll review the major preventable causes of maternal mortality and identify the critical role we can play in reducing those complications. And most importantly, and this is really the theme of every Stoelting conference, we'll look for new opportunities to work together, to break down silos, find new solutions that maybe none of us could have accomplished on our own. So this conference is about imagination, courage, and action. I'm really grateful to you all for being here. I appreciate the expertise and the passion that you guys all bring. And I think together we can chart a new cause for maternal health. Meghan and I really look forward, we've had a fun time putting this together, and we look forward to sharing this experience with you over the next couple of days.
Thank you, May.
Yeah.
Good morning, everyone. So my people hail from the South, and we do something called call and response, so I can't actually start until you say something. So I'll say good morning. Excellent, I love it. It's great to see you all. I have to give a special thanks to May, who's been a phenomenal partner throughout this whole process and is a guiding light in anesthesia safety for obstetrics, and for helping us think really broadly about how we can make an impact on maternal health. Now, it's helpful for us sometimes to know who's in the crowd. So how many of you have been to a Stoelting conference before? All right, welcome back. For those of you who have never been, this is a phenomenally collaborative time. We want you to get to know each other. We want you to talk to each other. This is the magic of a Stoelting conference. We have clinicians, we have patients, we have industry representatives, we have all kinds of people who are interested in this topic from lots of different vantage points, and really we're able to make change when we work together and we talk together. You'll note that we use a lot of first names because we try to be as collaborative and friendly and have as flat a hierarchy as possible. It's not to disrespect anyone. But we hope that you have a wonderful time. So I want to introduce the president of the Anesthesia Patient Safety Foundation because Dr. Cole, Dan Cole, will contextualize how important this topic is in everything that we do as anesthesia clinicians and those that interface with us. You might be thinking, what do anesthesia folks have to do with maternal morbidity and mortality? And we think everything, but I'm hoping that Dan will give us a little bit more color to the conference that we're about to kick off. So Dan, come on up.
Well, thank you, Megan. And do you have my slide deck up? I just have a few slides. I wanted to introduce to some of the new people, APSF, what we do, who we are. And that's not quite the right one. I'm not prepared to give that lecture. That's it. So thank you, and I can't tell you how excited I am to hear this topic. It's long overdue. Maternal safety, maternal outcomes has been a plaguing problem in the United States. It's an area where we should be number one in the world, and we are far from that. I do want to give my own thanks to the planning committee. They put a lot of effort into it. They have a lot of enthusiasm and passion for this. So again, thanks to all. You can see them here. This is our 40th anniversary of the Anesthesia Patient Safety Foundation founding, the first patient safety group in the United States. At the top left corner, you can see the original founders of Anesthesia Patient Safety Foundation. At the bottom, you can see the current board as of a couple of days ago. There's always a couple of people that change with our board meeting, which we held yesterday. We work in several different domains, but we support research, so new knowledge to kind of advance the field and patient care. Education, we have several education products that are on. Everything that we offer is free of charge. We're about a cause, not about a business operation. Communication, we have a newsletter that is free, read by 700,000 people worldwide and translated into 9 different languages. Very excellent. Our website is visited by over 1 million people each year. And then finally, there is a mountain of things that we could be working on in patient safety. We can't do everything on our own, and so part of our initiation is collaboration. And collaboration is important because when we work together, we get a little more done, or sometimes a lot more done. So that is a strategic focus of us. Here are our patient safety priorities, and this has changed a little bit in the last few years, but you can see there are now 8 of them listed on our website down below. The 3 that are underlined, we've combined into one patient safety priority because we found that there was a lot of overlap. We have patient safety priority groups that work on this area. And just yesterday, we decided at our board meeting and part of the strategic planning process to spend significant time, some resources developing and improving culture. The project plan has not been worked out yet, but we expect in the next few months that to develop. We've also gone beyond, and we tried to be patient-focused, but we've gone beyond just the intraoperative period into what the patient sees, is the whole perioperative or obstetrical, peri-procedural episode of care. And so we've expanded our focus to include the entire episode of care down below. Next year's conference, just a highlight for this. Della Lynn, who is here, will be the program chair of that conference. And we're going to talk about the 30-day perioperative journey with a specific emphasis on safety and perioperative outcomes for the 30-day journey. So that'll be at National Harbor in Maryland, so put that on your date. Again, it's the Wednesday and Thursday following Labor Day. We do want to thank our industry supporters, something that is unique about the Anesthesia Patient Safety Foundation. Oh, did I do that? Anyway, can you go back one slide? No, back. It's one more slide. Yeah, thank you. We want to thank our industry supporters. Without them, this meeting would not be available. Again, this meeting is free of charge to the participants, and we thank you. But again, we thank our industry supporters for supporting this meeting. And we operate totally on donations. Everything, again, is free of charge, but if you feel so inclined, there's a QR code there, a QR code in the back. I'm not even touching this. Do you know why this keeps advancing on its own? Go back one slide, please.
There we go.
Yeah. All I'm doing is holding it, so I don't know if it's going to be a problem for future speakers. So sorry about that. It seems like anesthesiologists should be able to figure out technology, but I don't know. Yeah, we'll get it. And if you're a recurring annual donor for $250 or more, we're happy to send you this APSF branded vest. And my last slide, again, I kind of want to quote Dr. Pierce, who is the founding president of Anesthesia Patient Safety Foundation. Patient safety is not a fad. It's not an objective that has been fulfilled. It is an ongoing necessity. It must be sustained by research, training, and application in the workplace. Those words ring true today. They were stated like 40 years ago. And again, thank you for all your support of our shared goal. With that, I'll turn it back to the meeting planners. Thank you.
Thank you, Ms. Elliott. All right, hello again. We're actually running a little bit early, which is great because that'll give us more time for discussion. I'm sure we will run over at some point. So it's my great pleasure and honor to introduce our keynote speaker, Dr. Elliott Main. Elliott sort of embodies the relationship between OBGYNs and those that care for birthing people and the anesthesia care team. We actually work really closely together to make sure that patients get through the peripartum journey safely. Elliott is a professor of obstetrics and gynecology at Stanford. His full bio is in our program and online, but I just want to highlight a couple of facets for you. Elliott's an internationally recognized physician, researcher, and advocate for maternal health. He has more than one really big achievements, but the one big crowning achievement is that he's the co-founder and former director of the California Maternal Quality Care Collaborative, the CMQCC. It was founded in 2006 and has been working since that time to decrease maternal morbidity and mortality in California. The CMQCC is credited with a 65% decrease in maternal mortality in the 10 years after its founding. And I encourage you all to go to the CMQCC's website. There's a pretty stark graph that shows how maternal mortality in the US continues to increase over time, except in California, with an inflection point after the founding of the CMQCC. So it really is an amazing achievement, and hopefully they offer some insights into how we can all achieve those improvements. The work that Elliott did with the CMQCC led to his being awarded in 2024 the Joint Commission Eisenberg Patient Safety and Quality Award for Individual Achievement. On a personal note, I've gotten to work with Elliott a little bit as part of the Improve Initiative, which is an NIH-funded initiative to decrease maternal morbidity and mortality around the country. So the NIH founded that initiative in 2019, and they stood up 12 maternal health research centers of excellence, of which Stanford has one, and Elliott is the lead on one of the projects there. And I co-direct one of the implementation science initiatives as part of that. So I've gotten to see some of his work through that. But he's also been a part of our planning committee. And I remember when May and I were thinking about this, and she threw out Elliott's name, and we thought, is he gonna answer our emails? Is he gonna even talk to us, let alone be on our planning committee? And he's been an amazing partner. We've learned so much from him, and we will learn a lot from him now. So it's my pleasure to introduce Elliott to the podium for him to give us a keynote to kick us off on this really important topic. Elliott, please come up.
That was very kind, and I think it's really to make progress in this field, we have to do a lot of collaboration. I do a lot with neonatology, we do a lot with internal medicine, but anesthesia really is the key because they are the people who are our backup on labor and delivery. You all are our critical care, not only backup, but right there with us. And so we really need to be working on this together. And I think I'm going to show some of the ways that we've worked together over the last 15 years and where we can go in the future. So today we're going to review some of the current data around maternal mortality, severe maternal morbidity, but really with an eye on implementation of improvement projects. And we're going to look at some of the things we have to do to address the very significant disparities that we have in this country. And, of course, recognize the potential roles for anesthesiologists in these areas, which is the whole theme of this meeting. My only disclosures are that I am a consultant to CMS, the Joint Commission, and ARC on creating and modifying and improving new measures for severe maternal morbidity. Now, as a medical student and a resident, you're always trained to read the New England Journal of Medicine, and there's not much about obstetrics in the New England Journal of Medicine, and in fact, for many years, this was the go-to piece in my training. These were case studies published by the Massachusetts Medical Society of terrible obstetric cases in detail, and you didn't see this in OB journals. This was basically case reviews with an understanding of how to improve outcomes. And they were really trained. I don't know how many people have read this in their part of their training. They stopped this about 15 years ago, but these were formative. And they were formative in conjunction with the other leading publications that came out since 1950s through to today, which is the confidential inquiries in the UK. Confidential inquiries are published every 3 years by the Royal College of Obstetrics and Gynecology, and they review all maternal deaths in the UK. Now they've added Ireland and Scotland and Wales, and they're a treasure trove. And they've morphed over time. Now it's the UK mothers and babies reducing risk through audits and confidential inquiries, Embrace. I think the confidential inquiry is a little simpler. But the problem with the confidential inquiries, as great as they were, is they were only published as a monograph every 3 years, which limited availability. But the only place you could find that it published in a journal was in the British Journal of Anesthesiology. They came out every 3 years with a summary. And so that was go-to reading. And that led me actually to this organization, observing, as I was doing quality improvement work in obstetrics, wondering how anesthesia had done so well over time. Clearly, you all have gotten a lot of attention from medical journals, but even the Wall Street Journal, with how well anesthesia has performed in improving safety and quality over the years. And so this was a model, actually, for me. My journey actually started as a maternal fetal medicine specialist at WashU, Penn, and UCSF, but I morphed into the M in maternal fetal medicine, whereas most maternal fetal medicines are focused on ultrasound and prenatal diagnosis. I really chose to take care of the highest risk women, and that led me to quality improvement, which in turn got me into large-scale quality improvement with first the perinatal quality collaborative with the very first one, and then as maternal mortality started to rise, the state asked me to develop a program that was focused on the mother in California. the CMQCC, where I've been the director for 17 years, stepped down 2 years ago. And to do that, you have to go to the source data. And I started our first maternal mortality review committee in California. California is the biggest state by far in the country. 1 out of every 8 births in the US is in California, 12%. So we have a lot of births, 500,000 a year, which means that unfortunately we have our share of maternal deaths to study and review and improve upon. So CMQCC took this data. We did these reviews with the concept that not just to categorize the deaths, but to see what quality improvement lessons we could learn from each and every one, and then to package them into quality improvement toolkits, and then do very large-scale quality improvement collaboratives, 100 hospitals, 150 hospitals at a time. And that's what it takes actually to move the needle. This led to really national efforts, and that's where I'm going to be going next, is the National Partnership for Maternal Safety, which then morphed into AIM. So I'm going to divert a moment and talk about my influences by anesthesiologists. In our initial work on maternal mortality reviews, we really stressed the importance of anesthesiologists. Sheila Cohen, who many of you may know, Grand Dame, an anesthesiologist, was one of our first co-leads, Ed Riley and now Alex Butwick. And when we started the national partnership, which became AIM, that was Jill Meyer, Barbara Scavone, and Paloma Toledo. And then at Stanford, I'm blessed with a wonderful department of anesthesiologists to collaborate with on a variety of areas. As listed here, and Brendan Carvalho and I were invited to go and work with the WHO on maternal hemorrhage. So it's been a very productive relationship all the way around. But I want to add a special call out to Brett Gucci, who was probably the leading OB anesthesiologist in Pennsylvania and Philadelphia when I was there. And just as a short story, top of my list was my last day on call as a junior attending at Penn. I struggled with an unexpected, undiagnosed placenta accreta. 25 units in a hysterectomy. We saved the woman, and she did well. But it's hard to recall a time in which placenta accretas were something that might happen once in your life. That's how much has changed in the last 40 years. Where placenta accretas, every big center here has a placenta accreta center. You know, it's that didn't used to be the case. Melissa Bauer, also a special call out. She'll be here tonight. Her kids are actually first day of school, so that's why she's coming a little late. And I are co-PIs on a NIH grant for sepsis that is large-scale implementation in 2 states, Michigan and California. And that's been a really exciting opportunity to work together with anesthesia in 2 states. So let's talk about maternal mortality causes here. And this is a classic study led by Andrea Krianga from CDC at the time, with trends over time and trends by causes. And you can see on the left-hand side that the more obstetric or direct causes of maternal mortality have fallen some: hemorrhage, hypertension, infection, pulmonary embolism, et cetera. And on the right-hand side, you see the, quote, indirect or medical causes all rising significantly. Cardiovascular disease, incredibly so. And that's going to be our next talk. That's really a very important topic for us, which you all are even more versed in than we in obstetrics. But let me look at the center. There's very small numbers for anesthesia. When you blow those up, this is a pretty remarkable story. And again, why I've modeled a lot of what we do nationally around the Patient Safety Foundation. Anesthesia deaths, anesthesia maternal mortality deaths illustrated here, fell from 2.5 in the late 1980s to 0.2. So I'm not here today to talk about how to give better anesthetics. That's not the issue. The issue is how we all in this room can do better for all the other causes, both on the right-hand side and the left-hand side of this curve. So maternal mortality, as May said, is high and rising in the U.S. This is the latest data. It doesn't show the tail on the far left. We used to be in the low teens and in the 20s, compared to other high-income countries that were in single digits. Canada, UK, many others are 6 or 7 or 8. We've been in the teens. With COVID, as to see the peak here, that hit mothers particularly hard. We're in our 30s. 35 was the peak in 2021. That's come down as COVID has moved on, partly. But it's moved on, so now we're still in the mid-20s. This is way higher than it should be. Let's look at a little bit of how maternal mortality compares to maternal morbidity. Again, this is a rough distribution of the major causes. In some data, both AFE and VTE are combined, so apologize for that. But you see, cardiac disease is well over a quarter of all the deaths in and of itself, and that how infection, hemorrhage, preeclampsia, and emboli are all roughly the same, 12 to 14% up and down, depending on the year. Thank you very much. Now, when you go to one measure of maternal morbidity, and this is, note that these maternal deaths, even though they have a high and scary rate, are really kind of infrequent, 1 to 2 per 10,000 births. When you look at ICU admissions as a measure of severe morbidity, it's 1 to 2 per 1,000, okay? More in a big center, of course. But now you see the distribution of causes changes considerably, with many more mothers admitted to the ICU are there for hemorrhage and preeclampsia than the other causes. When you look at the current CDC measures of severe maternal morbidity, which is about 1 to 2 per 100, so these are log differences, each of these steps. 1 to 2 per 100, more than half of those are related to transfusion. But now look at the distribution. This is dominated by hemorrhage and preeclampsia. 70% of severe maternal morbidity, maybe even a little higher, is hemorrhage and preeclampsia. So this is the trend line for severe maternal morbidity, CDC definition. There are other definitions out there, but the CDC definition is the most widely used. And this has been trending up. So not only do we see a rise in maternal mortality, we see a rise in severe maternal morbidity. In this case, it's driven 2/3 by increase in hemorrhage and transfusion. But even non-transfusion, all the other causes have gone up by 24% over these 6 or 8 years. So as part of our maternal mortality reviews, as I said at the beginning, we are looking very carefully at underlying cause, what's the drivers? Patient drivers, facility drivers, provider drivers. And we found a huge proportion of provider QI opportunities in 95% of the cases of hemorrhage and preeclampsia. This is actually supported with identical findings from big reviews in this state of Illinois, in two large studies there as well. And these provider opportunities can be categorized in the 3 deadly Ds, as I call them, in denial, delay, and dismissal, not listening to the patient, dismissing her fears or concerns. So we've got to remember those: denial, delay, and dismissal, and particularly as we look at disparities. These raise their head there quite a bit. So let's fast forward to the national scene. And this is an article that Barbara Scavone and I wrote in Anesthesia about the formation of a national partnership for maternal safety. That was a call for action in 2015. At the same time, we did the first national safety bundles, which was on obstetric hemorrhage. This is the beginning of AIM. And we did all these with multidisciplinary, multiple specialties, nurses, physicians, and all kinds of physicians and patients involved for each of the bundles. This morphed, the national partnership morphed into AIM, which was, in back of my mind, modeled after the Anesthesia Patient Safety Foundation, but we didn't have industry support. There's a lot of technology in anesthesia, less so in obstetrics, but we did get federal funding. Federal funding is nice when it's nice, but right now it's not so nice at the moment, shall we say. And AIM was funded by HRSA, and actually is now a line item in the federal budget. Called out to support. So we've made progress on that. So it was formerly known as the National Partnership, that it became AIM. So an AIM bundle is basically a checklist of items and practices on a given topic that should be adopted in every birthing site. They're short, 2 to 3 pages. They have a list of types of things you should do and some implementation ideas. So they have a 5R structure: what you need to do for readiness, recognition and response. That's what most of us think about is response, how you're going to respond to an emergency, but there's a lot of background that you have to take care of to make that action functional. And then you have to learn from it, which is the reporting and system learning, and in a context of respectful care. So there's items on all of these. We have 8 core bundles: hemorrhage, hypertension, cesarean reduction, cardiac conditions, sepsis, transition to postpartum care, mental health, and substance use. These are supplemented by what we at CMQCC call toolkits, which provide detailed background, example policies and procedures, everything you need to do real implementation. These are long, these are basically monographs, 120, 160 pages, because they're chock full of ideas and background materials. They've covered 6 of the areas as noted, but they've been widely popular. Downloaded, these are freely downloadable, and they average 10 to 14,000 downloads. Open source at cmqcc.org. We have a new one on maternal sepsis, an upgrade, major upgrade that Dr. Bauer and I have led. That is actually going to have a release webinar day after tomorrow when I go back to California. And everyone is welcome to join. So far we have over 900 registrants to the webinar. So AIM itself is now in all states except Wyoming, which only has 6,000 births, doesn't even have a medical school or a tertiary center. But it's made significant inroads at various levels, I'd have to say, but it has a presence. The hemorrhage and hypertension bundles are the ones most widely used, but I'd like to point out that it's not just doing the right thing, but in obstetrics and probably in anesthesia, timeliness is critical. In hemorrhage, every 5-minute delay before a second uterotonic can result in a 31% higher rate of hypotension. 10-minute delay in anesthesiologist involvement. This is one of my favorites. If you don't call the anesthesiologist to the bedside in a timely way, that increases the severity by an odds ratio of 1.6. Okay. Essential previa, as you all have, many of you have seen, can lose the woman's entire blood volume in 14 minutes if it's wide open. Hypertension, there's a big effort nationally to treat severe range Systolic blood pressure within 60 minutes. It should be 30 minutes, but that's what we settled on as a national target. It's actually going to become most likely a Joint Commission performance measure in the next year. So that's something that you all will be paying attention to as you work with mothers getting regional anesthetics and saying, do I treat, do I not treat? You need to treat. Sepsis, it's, as you know, in non-obstetric settings as well, you've got to get the antibiotics and the fluids in as quickly as possible. So how do you push implementation? And no one likes to change just because they want a new set of clothes. People need to have some incentives to actually change their practices. So we've gone to the big boys, if you would. Big boys are the people who do accreditation, the people who pay, i.e., and those are ones we've gotten involved. For the Joint Commission, accredits 85% of the hospitals in the country, and they have taken the AIM bundles for hemorrhage and hypertension and rewrote them in Joint Commission language. It's a translation, literal translation, of the bundles into standards. Standards is a tough word. Standards is what a Joint Commission assessor, surveyor will look at when they come to visit your facility. And so instead of the surveyor coming to my unit as chief of OB and saying, can I see your crash cart? Which has no meaning in OB, but that's what they used to know how to do. They may have looked in the ORs to see if the standards were the same as the general ORs as well, but nothing really to do with obstetrics. But now they are given the tools to look at how you handle hemorrhage and how you handle preeclampsia, and are you following the national bundle. So this is a big step. The second big step was for CMS to decide that severe maternal morbidity was a national outcome measure and should be reported at the hospital level. CDC uses it as a population health measure, but now CMS with the Joint Commission have turned this into a hospital measure with key caveats, with key changes, such that it is risk adjusted. Conditions that were indicators for severe maternal morbidity that were present on admission are not counted for the hospital. And it can use additional data besides ICD codes, such as labs and some vital signs on admission, and the risk adjustment algorithms. So this is a step forward. It is now, though, required, mandatory for every hospital in the country with 2024 data. So this is happening. It still needs some refinement. Some hospitals are having some trouble with SNOMED codes and some of the other new things. But this is actually going to be part of the birthing friendly initiative that CMS has rolled out. That's going to include the low-risk first birth C-section rate, the severe obstetric complications, which is their name for severe maternal morbidity, as well as adoption of national safety bundles. So that's in the mix as well. So have we moved the dial? May mentioned that we have lowered the maternal mortality rate in California quite significantly. I didn't choose to show that slide today. It's pretty dramatic, though. But we have, because we wanted to focus on severe maternal morbidity. And there's a study from California and a study from Texas showing that you can significantly reduce, or this second study is from Illinois, actually, that just came out a few months ago, showing that you can reduce severe maternal morbidity from hemorrhage and hypertension using large-scale quality improvement projects. However, we've done less well with some of our population, and particularly persons of color. On the right-hand side of this is in-hospital deaths per 100,000 for a Black, Hispanic, Asian Pacific Islander, and white at the bottom. And one of the national disgraces is that Black women have 3.5 to 4 times, depending on which specific measure you use, higher rates of maternal mortality than white. There isn't any other measure I can think of that's anywhere near that disparity, 3 to 4 times higher. And that's held true, as you can see, in 2 different time periods. It is nice that this is in-hospital mortality, as opposed to the more general maternal mortality, which includes out-of-hospital, of course. And we're going to talk about that, particularly cardiovascular disease, in the next talk. But this is showing that it has reduced some in this time period, which is encouraging for what we have been doing in the hospital for acute care that we all think that we're addressing the issue for. On the left-hand side is severe maternal morbidity, and that's been rising. The blue is the most recent time period, and that also has a major disparity. It's a little more than 2 times higher in Black birthing persons and about 40% higher in Hispanic. Some of this is related to comorbidities, but comorbidities isn't a reason for us not to strive harder. Okay. So when we've done large-scale quality improvement projects on trying to address disparities, we have mixed results. We do, actually, most quality improvement projects do much better looking at process measures than they do at outcome measures. Outcome measures are notably harder. So in this case, the process measure on the right-hand side was to treat women with severe blood pressure in a timely way. And they were able to show that, a couple studies have shown this as well, at single hospitals. They can show that they are now treating everyone the same, but that doesn't mean they had the same outcomes just from that, improving that one process measure. When we did that on the left-hand side here in California, looking at hemorrhage rates, we could show significant reduction in morbidity in Black birthing persons or Black mothers by our participation in our hospitals that participated in our collaboratives. But there was still a residual, and the residual actually was interesting because it was largely related to higher rates of anemia and much higher rates of C-section in Black mothers. And so these can be complex, the drivers, as pointed out. So I'm going to, as I approach the end, I'm going to be talking about the key principles that we've had identified. I talked about the 3 deadly Ds before. Now we're going to have a bunch of Ts. Teamwork is obvious. We have to be working together. We need tools or toolkits, direction and timeliness. And I'm going to add trust to this. And trust, i.e. Getting rid of dismissal, is a really key issue that we're also going to be talking about later in this meeting. Many persons of color do not trust us. And it's hard to provide appropriate care in that setting. And if patients are disrespected, they're not going to come back. They're not going to do what we ask of them. And so our challenge is, as an anesthesiologist or as a hospitalist OB, is how you develop trust in 5 minutes or less. So I think we all can develop our own strategies, but that's a conscious thing you have to be working on. How do you develop trust in under 5 minutes? And a lot of it is about sitting down and asking what their goals are, what they want out of this opportunity. So with that in mind, we've really taken a direction of how we can improve communications with our patients, make them aware of what's going on, starting with an urgent maternal warning signs, which is now in 90 languages. It has drill down on it, which is very, very exciting. It's modeled after the CDC Hear Her campaign. It's available for free from the ACOG AIM site. We are putting this up throughout our labor and delivery units, in triage, in labor rooms, in prenatal office walls, as well as putting it, we've developed ways of putting it on the phone so the patient and their partner can see the urgent warning signs in their own language. As part of our sepsis grant, we, with the community engaged group, we developed advocacy tips for patients in English and Spanish, and also it's one thing to have urgent warning signs, it's the other thing to have the patient listened to by the triage nurse or the triage staff. So we've been working on that with warning signs follow-up. So I'm going to leave you on the second to last slide with an expanded view of maternal deaths. This is a classic circle, circle, circle slide, whereas the traditional definition of maternal mortality, which is 42 days and related, is the small one at the bottom. Pregnancy-related mortality, which goes out to a year, encompasses about a third of all deaths that happen to a pregnant person within a year of delivery. The rest are pregnancy-associated deaths, which we didn't use to count. So cardiovascular disease is the big driver in this period after delivery, but within a year. But as we look at that time period, that very large group of patients in that time period, up to a year, that is pregnancy-associated, maybe not related to substance use, suicide, and trauma. Those are the big ones out there that are now being eyed to being counted. So I'm going to end with a statement from your society, the American Society of Anesthesiologists, in October of 2022, as to what your role is on reducing maternal mortality and severe maternal morbidity. The top 5 of these above the line are high-level or state or national actions. We've been talking about these already. The other 4 are hospital-level activities. And I'm hoping that when we're done here on Thursday, we can add a lot more to that list. Because I think we have a last mile issue. We know what to do in the big scale. We know nationally, we have bundles, we have toolkits, et cetera. But it's that last mile that we really need to be working on. What happens at the bedside? How can we move beyond the bedside, actually, for some of these causes? So we're looking at below the line activities. So thank you very much, and I look forward to the meeting. Yeah. So I get to stay up and introduce our next group of speakers. Okay,
Elliott?
so we do.
Yeah.
I love questions. So since we're ahead and I spoke fast, we get a few questions.
I have the microphone.
May, here.
Oh, here we go, JW.
Thank you for that great lecture. Could you talk a little bit more about the diagnoses that are present in the cardiovascular disease comorbidities? Hypertension appears to be listed as a second group. So maybe specific diagnoses and any opportunities to recognize those earlier in pregnancy?
So there's 2 major categories that make up cardiovascular disease deaths. One is underlying cardiovascular disease, largely both acquired and congenital anomalies. That should be identified and known ahead, or maybe not. We have a lot of immigrants in this country who may have unrecognized heart disease. So that's one big category. The second big category, which is particularly postpartum, this is the next lecture, is going to be cardiomyopathies. And those some of those may be related to hypertensive disease. Severe preeclampsia can be devastating in some of the cases and go into heart failure in the first weeks after delivery, but others can be more delayed, even up to 4, 5, 6, 7, 8 months after delivery. And they all have a common pathway of heart failure. The unfortunate issue is that heart failure symptoms are similar to postpartum symptoms, tiredness, fatigue, and they often get dismissed. This is a classic dismissal situation. On maternal mortality reviews, almost all these patients went to ERs 4 to 5 times before they died and were dismissed. So there are some real opportunities there.
I'm here, May.
Oh.
Hi, Elliott. Rick Dutton from U.S. Anesthesia Partners. Thank you so much for the presentation. Appreciate the overview, and thank you for being here with us. I'm going to ask a glass half full kind of question. How much, in your estimation, of what we're looking at in the statistics you showed is due to, first, better data gathering, largely through your efforts and others to show the problems? So one comment internationally is we do a much better job of identifying OB, morbidity, and mortality, so our rates are higher. And the second point, or the second question for you, is you mentioned the demographic change over the years, for instance, in the percent of patients dying from hemorrhage or placenta previa. Clearly the incidence is higher. But the incidence also becomes higher as other diseases go away. So what have you seen as successes in OB care and OB anesthesia that have been where we've removed sources of morbidity and mortality, causing us to see rocks now emerging above the water? Thank you.
So there are data challenges with maternal mortality, largely because it is such a small number that fluctuations in how you collect it will have a significant impact. However, there's no question that it is higher than other countries. I recently gave some lectures in Singapore, which is a very multiracial society. And they have almost negligible maternal mortality, a very good health system, very good access to care, and so forth. And it's eye-opening what can be done when you have a health system that's focused on caring for everyone. The multicolored graph that I showed toward the beginning that showed all the declines in the hemorrhage and hypertension and the rise in others is a little deceptive because it's the percent of deaths attributable to those causes. So percents are a zero-sum game. If one goes up, the others have to go down. And I published an article recently in an epidemiology journal that showed that the rates of the direct causes, hemorrhage, hypertension, trauma, have not really gone down. Their proportion's gone down, but they're flat over the last 15 years. So we haven't made that significant, anesthesia was too small to really do that analysis on, but the other causes were flat. And what has really happened is that we're identifying and counting a lot more of the cardiovascular disease, the medical complications of pregnancy, and so forth. So those are what's gone through the roof. But the direct causes, what we formerly call direct, are flat, not really improved. So we still have work to do on the simple ones that we think of, the hemorrhage, hypertension ones that people shouldn't be dying of. So at the same time, we are struggling with inequities in care in this country, and that does make it harder on us as providers, no question. So it has to be all of us together, as well as big organizations and providers and Medicaid and so forth. I think that's probably my calling to move on to the next part of our session. We're now going to move into a series of shorter talks in which we have what I could call an all-star cast that's going to talk about the big 4 drivers of maternal mortality. Jennifer Banayan is going to be from Northwestern. who's an anesthesiologist with cardiothoracic training. And it's cardio-obstetrics is now an emerging field for the reasons that Jennifer will talk about in her talk on cardiovascular disease. Emily Naum from Mass General, who will be talking on sepsis, and she's done some interesting work in ECMO, which is, I'm sure, an outgrowth of the COVID experience. Beth Clayton, as a professor and director of nurse anesthetists from the University of Cincinnati, is going to speak to us on hemorrhage. And Elisa Leffert, who's now the chair of anesthesia at Yale and formerly director of Mass General for OB anesthesia, is going to talk about her long-standing experience with thromboprophylaxis and other coagulopathies in her talk about venous thromboembolism. So this is going to be a series of rapid talks. We look forward to it. Thank you.
Okay, good morning, everyone. For those of you who don't know me, my name is Jennifer Banayan. I am an obstetric anesthesiologist at Northwestern. I was invited today to talk about cardiobstetrics, a field that's increasingly central to maternal health care. As Dr. Main highlighted, cardiovascular disease is the leading cause of pregnancy-related mortality, and pregnancy really places unique demands on the cardiovascular system, and managing those risks requires thoughtful care. So I'm editor of the APSF newsletter, but I don't have any other disclosures. So I want to start with the case. This case really stuck with me, and so I just want to briefly talk about it and really what got me into cardiobstetrics. So she was a 34-year-old G1P0 without any known cardiac history. And she came to the hospital late in pregnancy, and she was complaining of shortness of breath. And we couldn't tell at first if it was normal physiology or maybe some sort of asthma attack. But then in front of my eyes, she started to decompensate. We did a bedside POCUS, and I thought maybe her ejection fraction looked like it was beginning to be diminished. And so I got worried, but we moved quickly. We consulted cardiology, we moved toward her delivery, and she just kept worsening. And as soon as she delivered, she crashed on us. So we rushed her to the cath lab where she got a balloon pump, and thankfully she survived. But this patient taught me something I didn't expect. I am a fellowship-trained cardiac anesthesiologist. I work in one of the busiest obstetric units in the country, and I should have been ready for her. I didn't have a plan, even though I should have. I didn't have a clear protocol of how to handle what was going on. We didn't really have a system in place. We were kind of improvising the whole time, and she was decompensating in front of us. And that really made me realize if I wasn't prepared, how many others are not prepared. And that's really why I have such an interest in cardiobstetrics, and that's why I'm here talking about this today. So in this talk, we're going to talk about the prevalence of cardiac disease in pregnancy. I want to talk about how it's a leading cause of maternal death. We're going to dig into why this is happening. We'll talk about when the patients are most at risk. And then finally, we're going to focus on how we start changing things. The goal really is simple. Can we be ready before things go wrong? So as we think about maternal mortality, it's important to start with the fact that measuring it accurately is not really straightforward, and Dr. Main kind of alluded to that. There are many publications and studies, and each of them uses something slightly different data sources. There's different time frames, there are different definitions, but whether we're looking at CDC or state-level maternal mortality reviews or large-scale studies, like the recent JIM analysis, no matter what we look at, cardiovascular disease is really consistently the leading cause of pregnancy-related deaths in this country. Again, depending on the source, cardiovascular causes account for a third of pregnancy-related deaths. They surpass hemorrhage, hypertensive disorders, infection. In fact, between 1999 and 2021, the rate of mortality death from cardiovascular causes tripled. This pie chart that I made kind of breaks down the cardiovascular causes of maternal mortality, like Jada was questioned. And as you can see here, peripartum cardiomyopathy stands out as the most common cause. And given its prevalence and impact, it's really a central focus of a lot of research and a lot of clinical interventions. But we see also distributions from coronary artery disease, arrhythmias, congenital heart disease, and aortic dissection. And when I created this chart, I wasn't sure, should we include hypertensive disorders of pregnancy? Should we include thromboembolic events, which I know Lisa's talking about today, because they're often reported all the time, but they're separately. They're usually taken out. But because they have such an effect on the heart, I included them also in this pie chart. Most of you have seen this figure before. It's the classic representation of the hemodynamic changes that occur throughout pregnancy. And I'm not going to go into detail on these parameters, but the key takeaway here is that pregnancy imposes substantial shifts to support the fetal needs. And these changes become especially significant during labor delivery and the immediate postpartum period. These rapid fluid shifts and stress can tip the balance, and that leads to volume overload or cardiovascular decompensation, particularly in our individuals with heart disease. And so, in other words, pregnancy is really just nature's stress test. People have heard this before, but it's very true. And so during pregnancy, the cardiovascular system has to undergo these dramatic physiological changes. And these changes are well tolerated by healthy hearts. But then you have a patient with underlying cardiac disease, and it's unmasked or it's worsened by this pathology. So patients who may be previously compensated or they are subclinical disease, they will decompensate when faced with these volume shifts and hemodynamic demands of pregnancy. And for those with really no existing cardiac disease, this could lead to our heart failure. This is why we see the arrhythmias. This is when we get the ischemia. Because pregnancy itself doesn't cause a heart disease, but it does reveal it. So why is cardiovascular disease the leading cause of maternal mortality in this high-income country? Well, there are several contributing factors, and so we're going to take a closer look at each of these. Here is Janet Jackson, pregnant at the age of 50. And like her, many women are delaying childbearing. In fact, 15% of all births in this country are to women over the age of 35. But a third of the maternal deaths are also seen in that age group. So with age group, with a larger age, comes a greater burden of comorbidities. We have hypertension, we have preeclampsia, we're having thromboembolisms, we see diabetes, and all of those are elevating our cardiovascular risk. So when we talk about why maternal cardiac deaths are rising, the changing maternal demographics are really a big part of that story. And like we mentioned, not all cardiac disease is acquired. A growing number of patients are entering pregnancy with congenital heart disease. Thanks to major advances in pediatric cardiology and surgery, many of the patients are surviving into adulthood and considering pregnancy, and they have their own set of risks. In fact, the adult congenital heart disease population outnumbers children now in this country, and that's a testament to how far medicine has come. But these patients often face very complex challenges during pregnancy because their heart defects, the light's okay, and it repairs very widely. And that makes risk assessment and management particularly nuanced. Another reason cardiac disease in pregnancy is such a large contributor to mortality is that cardiac symptoms, like Elliott said, like shortness of breath, like palpitations, like edema, they are just so common in pregnancy. And so they're often dismissed as normal, especially if you have a younger, healthier looking patient and they're coming to the ER with them not feeling so good. They're chalked up for anxiety all the time. But if it's someone with undiagnosed cardiac disease, these symptoms are our first warning signs. And when they're dismissed, it delays diagnosis and treatment, and timeliness is everything. And so studies show that up to 3/4 of cardiovascular-related maternal deaths are preventable. And delayed or misdiagnosis is a major contributing factor. And so this tells us all we need a higher index of suspicion, especially when symptoms escalate or don't fit our expected physiological pattern. But even when we do recognize the risk, we often fail to act effectively. And it's not because we don't care, and it's because our health systems are so fragmented. Many patients don't get the opportunity for preconception counseling, especially if they're uninsured or have limited access to specialists. And even when someone is flagged as high risk, referrals are hard to get to. Their appointments are hard to make. It's hard to get a spot. And when patients finally do reach us, their care is fragmented. So OB is managing their problem, maybe cardiology is seeing their patient for something, and then finally anesthesia gets there, and we're brought in the last minute without full context. And so it really becomes especially critical in the postpartum period when many of these cardiac deaths actually occur. Follow-up care is delayed or inadequate, and many patients are not seen postpartum until they show up in the ER decompensated. Now, we can't talk about maternal mortality, I know Jill's talking about this later, but without acknowledging the deep racial and socioeconomic disparities that exist in cardiovascular outcomes. In the United States, Black and Indigenous women are 2 to 3 times more likely to die from pregnancy-related causes, and that, again, cardiovascular disease is a leading driver. These disparities aren't fully explained by income or education. Even well-resourced women of color experience higher rates of delayed diagnosis, dismissal of symptoms, and undertreatment. And the reasons are multifactorial: implicit bias, structural racism, and unequal access to high-quality care. And then there's the social determinants of health, so housing instability, insurance gaps, transportation barriers, chronic stress. That all adds another layer of risk. Addressing maternal mortality means addressing these systemic inequities head-on. So now we've talked about why cardiovascular disease is the leading cause of maternal mortality, but let's talk about when these patients are dying. When we talk about maternal mortality, we often focus on labor and delivery. But for cardiovascular disease, the deaths don't happen during delivery. In fact, studies show that over half of these deaths occur in the postpartum period, after the patient's left the hospital. And I, too, sit on the Illinois Maternal Mortality Committee, and I'm overwhelmed by how many patients go to the ER multiple times before they ultimately end up dying in their home. And so the timing varies by disease. So peripartum cardiomyopathy presents weeks to months after birth. But then an aortic dissection we can see right after delivery. And so for those of us who are anesthesia professionals in the room, our care often ends at delivery. But we may be the last person to see this patient, to identify the risks, to optimize the status, to raise concerns, especially in these patients who have really subtle symptoms. I think it's on us. So we've talked about the scope of the problem, the rising rates of cardiac disease at pregnancy, why it's happening, and when it's becoming dangerous. And the question is there anything we can do? What can we do? The first intervention is identifying the cardiac risk before pregnancy or early on in gestation. Now, as anesthesia professionals, we rarely get to see these patients before delivery, never mind before pregnancy. But more and more institutions are establishing prenatal consult pathways, and that does allow us to get involved earlier. These consults allow us to risk stratify patients and flag any concerns. We have tools a little bit now to help us. So we have Zahara, the MWHO, the CARPREG, and all those can kind of guide counseling and decision making. And even though if we're not part of the initial prenatal care, that can help us when we see the patient in the pre-op, when they come to delivery, we can gather, and hopefully that'll help the trajectory of care using those tools as well. Of course, identifying risk is only the first step. What really changes outcomes is what we do once that risk is recognized. And so that brings us to one of the best tools we have, which is multidisciplinary care. And one of the most effective ways we found to improve outcomes through pregnancy is through this pregnancy heart team. It's this team that comes together specialists. It includes OB, cardiology, anesthesia, MFM, nursing, and we all come together to collaborate. And the goal is better communication, safer, more proactive planning. It helps avoid the last-minute chaos of decisions when the patient decompensates. And studies show that institutions that have formal cardiac obstetric programs have lower rates of cardiac complications and better maternal outcomes. For anesthesia, being embedded in this part of the team makes a real difference for us. So at Northwestern, we recognized the need for this kind of coordinated care, and we built a formal cardiac obstetric program. We meet regularly and review every viable pregnant patient with a cardiac diagnosis, and it gives us a chance to make a detailed delivery plan before the patient arrives in labor. But this brings us to a really important point. While the pregnancy heart team is incredibly valuable, anesthesia needs a seat at the table. Anesthesia professionals have been managing high-risk obstetrics with cardiac disease for a very long time. We've been publishing our clinical guidance, our case studies, our institutional experience, and they're all in our own specialty journals, though. But as cardiac obstetrics has emerged as a formal multidisciplinary field, a lot of the foundational literature, like the AHA scientific statement and ACC consensus statements, they're all from cardiology. And finally, in 2022, the AHA approached a few of us as anesthesiologists, Katie is another author in the room, including myself, but to write a scientific statement on the anesthetic care of their pregnant patient with cardiovascular disease. The statement became one of the first articles in circulation focused on anesthesia's role in cardiac obstetrics, and it was a meaningful step. It said anesthesia isn't just a consult, we want to be part of the core team. And now it's really up to us to keep pushing forward, to write, publish, collaborate, and lead. Because when we are involved early, then we're embedded in the planning, outcomes seem to be better. So now that we've covered pre-delivery planning, we want to focus on the crucial role anesthesia providers during labor. So labor and delivery, as many of us know here, are intense cardiovascular stress, increased cardiac output, fluid shifts, and anxiety, and they all cause significant changes. And so our expertise in monitoring and managing these changes is really essential to help patients throughout their labor. Placing invasive monitors like arterial lines can help us give real-time data to catch subtle changes before things escalate into emergencies. Fluid management has to be really carefully tailored. Too much fluid and we're in heart failure, too little and we're hypotensive, not perfusing the uterus, and going to crash C-section. We've often the first to detect arrhythmias and intervene promptly to prevent deterioration. In rare but critical situations, ECMO can be a life-saving intervention. I won't talk much on ECMO, but the utilization of ECMO in maternal cardiac care has significantly improved survival rates in critical cases. For instance, in peripartum cardiac arrest scenarios, VA ECMO has achieved a maternal success rate of up to almost 87–90%, and nearly 80% of those survivors have no neurological deficits. So managing these patients during labor is critical, but it's only one piece of the puzzle. We've already talked about how the postpartum period carries the highest risk, so how do we manage these effectively? At Northwestern, we realized the standard postpartum care wasn't enough for many of these patients, and we built something different. I don't know why my slide is blank, but we developed an intermediate medical unit specifically for high-risk postpartum patients. One of these patients to stay close to their babies while remaining on continuous telemetry. This unit now has a higher nursing ratio, more frequent assessments, and really the ability to respond quickly if patients start to decompensate postpartum. And that is helping us bridge the vulnerable window between delivery and discharge. So I began this talk with a patient who told me how unprepared I was, even at a top institution, and then we talked about what's possible. Anesthesia professionals do have a powerful role to play in cardiac obstetrics, but not just in the OR. We need to recognize risk, we need to shape plans, we need to push for better systems. It's not just about preventing emergencies, it's about creating care models where patients with cardiac disease can deliver safely, recover well, and thrive. Thank you. I think Emily. Oh.
All right, hi everyone. My name is Emily Naum. I am a critical care and obstetric anesthesiologist at Mass General. I'll be trying to condense a pretty big topic about maternal sepsis into just 15 minutes. I do not have any disclosures. So what I plan to touch on in this talk today is how common sepsis is in our obstetric patients, the causes of sepsis, why it's really hard to identify, and the main points of management so we can see what areas can we really work on, because we can work on them to do better in caring for these patients. So what is sepsis? This definition of sepsis listed here, sepsis 3, is from the general population, and it has really evolved over the last 3 decades. Currently, we're using the sepsis 3 definition, which is just life-threatening organ dysfunction caused by dysregulated host response to infection. So maternal sepsis. In our population, we use the WHO definition most commonly. It's very closely aligned with sepsis 3, but you can see it adds the association of the peripartum period. So this is what sepsis is. How common is it? Well, determining just how frequent it is in our population is really hard because we've changed the definition of sepsis over the last 3 decades. So depending on how patients were identified to have sepsis in the studies that we have, the rates look really different. Having said that, as Dr. Main mentioned in his talk, the contemporary studies that we have suggest that sepsis occurs in 0.1% of deliveries in the US, or 1 in 10,000. Although this might sound rare, in studies of maternal ICU admissions, sepsis contributes to up to a quarter of ICU admissions, and those requirements seem to be increasing in the most recent studies. Beyond ICU admission, we know that sepsis contributes to a substantial chunk of severe maternal morbidity and mortality. Embrace UK, which was mentioned earlier, it's a collaborative that reports on maternal deaths and morbidity in the UK and Ireland, and it provides amazing data as to trends in maternal complications. As you can see from this figure, from the 2023 report, maternal mortality from infectious causes has not improved at all over the last decade, despite efforts to identify and treat sepsis more aggressively. And this is not only in the Embrace report, but many studies, when you look at this longitudinally, the rate is pretty stuck in the mid-teens for maternal mortality. This figure from the 2024 Embrace report shows that sepsis is the 5th leading cause of maternal death overall between 2020 and 2022. And so if you're thinking, we're America and we're different than the UK, well, think again. Our data from the CDC demonstrates sepsis was the 3rd leading cause of maternal death in 2020. And other epidemiologic studies have shown this rate has been flat. So again, 10 to 15% of maternal deaths are related to sepsis. So this is really important and a big chunk of maternal deaths that we can prevent. So what causes maternal sepsis? The most common cause does differ between studies, and in women who are pregnant, the primary source of sepsis is more likely to be pneumonia or urinary tract infection. In the postpartum period, it's more likely to be GU or a surgical site infection. Interestingly, in 1/3 of cases, we actually never identify a pathogen, and when they are identified, most commonly they're bacterial, E. coli, staph, strep A, and other gram-negative bacteria. These are the most common causes. Group A strep is not the most prevalent bacterial pathogen, but it is particularly virulent. And importantly, viruses that may have more severe clinical sequelae in the pregnant patient include Ebola, Hep E, influenza, which is still a major cause of morbidity, COVID-19, and varicella zoster. So it can be helpful to recognize who's at risk. Obstetric risk factors that have been identified in many studies, these listed here come from 2 or more studies, and that includes multiple gestation, preterm delivery, labor induction, surgical delivery, and postpartum hemorrhage. There are also medical and socioeconomic factors that have been identified in multiple studies, and this includes anemia, chronic heart, liver, and kidney disease, as well as obesity, African American race, and public health insurance. So now we know sepsis is important, and we know who might be at risk, so how do we actually identify these women? The standard sepsis scoring tools that are used in the general population are listed here. So this is SIRS, SOFA, and QSOFA scoring systems. And the Surviving Sepsis campaign, which is used by all intensivists to best manage patients with sepsis, they recommend that hospitals should have a sepsis performance improvement program and that we should use sepsis scoring tools in high-risk patients. So why not just use these for our patients? Well, we know there are physiologic changes of pregnancy that were very nicely outlined in Dr. Banayan's lecture. They mimic the physiology of sepsis. You have vasodilatation, a hyperdynamic state. And a multi-center case control study from 2019 found that the SIRS criteria was very sensitive but very poorly specific. And QSOFA was poorly sensitive but very specific. So neither of these work very well, and how can we think outside of the standard box to recognize when our peripartum patients are at risk? This is especially important because waiting for these patients to develop the telltale signs of infection like a fever, can actually increase their risk of death. Delayed recognition of maternal sepsis has been associated with increased mortality with every hour that passes without treatment. In this report of women who died from sepsis in the state of Michigan, less than 1 out of 5 were febrile when they presented to the hospital. And a quarter of these women never had a fever, and they died of sepsis. Because of this, I want to talk about specific scoring systems for this population. It's not just about one variable, it's the big picture. So there are a bunch of warning systems, scoring systems, screening tools, all developed for this population, and some of them have multiple parameters, some of them have aggregated, weighted scores, and not all of them are specifically for sepsis. And since that's not what this talk is about, I just want to talk about what I think you can really take away on the topic. They do exist, they are important, they are useful. I have pulled out the CMQCC sepsis toolkit to have a spirited discussion with an obstetric colleague who didn't believe that there was a patient in septic shock, and I think they're super useful. They can also be integrated into the electronic medical record and flag at-risk patients and help guide an objective discussion about the patient's vital signs and labs so that you can take action sooner. This includes starting antibiotics, getting source control sooner, and transferring to the ICU when it's needed. So I know it's a dizzying slur of acronyms, and I just want to say each of these do have their strengths, and to clarify, they're not all specific to sepsis identification. OWS, MEOWS, the maternal early warning criteria, and the SOS all do a decent job of identifying patients that are sick, and any of these can be useful. So I want to show you how these actually work. So here's a maternal early warning screening tool. This came from a large California health system, and they looked at pre and post implementation of this tool in nearly 120,000 deliveries. 2.3% of all their patients actually screened positive, and more than 80% of those cases actually had a physician come and intervene within an hour. That's super quick. This coupling of identifying patients with the maternal early warning system and then following a prescribed clinical pathway if they screened in is a great example of how to actually create system-level changes. So they had individual clinical pathways for common morbid events, including sepsis. They found that physicians actually followed the recommendations in these pathways 83% of the time. And sepsis was the most commonly screened pathway. It contributed to about 38% of ICU admissions. They noted a significant reduction in severe maternal morbidity when they compared pre- and post-implementation, and I think that's incredible. Earlier recognition translated to earlier management and better outcomes. So this is the treatment algorithm that they followed. Sepsis is on the far left, highlighted here. This standardized approach to management helps physicians be notified and then have a systematic approach to treating, getting labs, giving antibiotics, resuscitating appropriately, and calling for help in an ICU consult if needed. None of these systems are perfect, but using any of them is valuable to identify sick patients and manage them promptly to reduce morbidity and potentially mortality. We have a lot of pregnancy-specific tools because we know these patients have physiology that's hard to discern from sepsis. Vasodilatation with a slightly increased heart rate and respiratory rate, those are normal in pregnancy, and actually the literature has shown that a lactate elevation in labor can be normal. Pregnancy-specific warning systems do help to identify these patients at risk, and maintaining a high level of suspicion for infection is critical. These patients look so good as they're developing septic shock, and our responsibility is to act early. So managing pregnant patients, just to briefly touch on what could be a talk on its own. Pregnant patients with sepsis can be managed very similarly to non-pregnant patients. Antibiotics is key. Antibiotics targeted to either your suspected source or broad-spectrum antibiotics should be given as soon as possible. Delayed administration of antibiotics more than an hour is associated with increased mortality in both the obstetrical population and general population. The EMBRACE study from 2023 highlights that up to 3/4 of maternal deaths from infectious causes were considered to be preventable, and this is simply too high to ignore. So as we look for areas to improve, the studies show that we just need to open our eyes and see these patients. We're generally slow to act. Whether it's on the labor floor or in the clinic postpartum, it's really hard to recognize infection. And we know that we're slow to transfer to the ICU, slow to write for the antibiotics, slow to get those antibiotics to the floor, and slow to get them into the patient. So to really hammer it home, the antibiotics need to get in as soon as possible. It's so important. 2 large retrospective studies found that only 10 to 13% of patients received antibiotics within an hour. And even when you had an ID specialist, only 2/3 of them had appropriate antibiotic coverage. So of course we want to be good stewards. And to all my pharmacy friends, I am a good antibiotic steward. But when it comes to these patients, every minute, every hour counts. Beyond the individuals and teams that care for these patients, our systems can work to drive down the rate of morbidity and death from sepsis. Multidisciplinary reviews for systems improvements should be conducted for cases of maternal sepsis to really look and critically evaluate that screening program, how the quality of care that patient received chalks up, and whether bias may have affected care. Process mapping may aid in identifying gaps, trends, and measuring change. And finally, collaborating can help smaller centers capture and review what is a relatively rare event to improve their management and outcomes. Finally, other opportunities for improvement in this realm include simulation, which has been shown to increase medical knowledge of providers who participate. Cognitive aids may help providers think of sepsis and then approach it systematically. And I know I shouldn't have left it to the last slide, but I did. We should empower our patients to know what is and is not normal for them, recognize the signs of infection, and present to a medical provider as early as possible for evaluation, and we should listen to them. I really appreciate being able to give this talk about an important source of maternal morbidity, and I hope it's been helpful to highlight key points that we can work on to improve patient outcomes. Despite our increased awareness of maternal sepsis, morbidity has not decreased, and making the diagnosis can be challenging. So be suspicious, use maternal early warning systems, and act quickly, act collaboratively to provide the best care to these patients. Thank you so much. Oh, that's me. Oh, okay. All right.
Good morning. I'm Beth Ann Clayton, and I am a nurse anesthetist from the University of Cincinnati. And I'm honored to be here today. The majority of my career over the past 30 years has been spent in obstetric anesthesia, and it's really exciting to be able to present on this topic, maternal hemorrhage. I apologize. I have really poor eyesight, so I can't see that screen, so I'm just going to be using both. And if I don't advance a slide, please let me know. Yes, if you can make that the bigger on the left, that would be really helpful. Thank you. Okay, so postpartum hemorrhage, as we've heard this morning, unfortunately, it remains a leading cause of maternal hemorrhage, both for mortality and morbidity. And despite the global awareness and evidence-based guidelines, there are gaps in timely diagnosis and the management of that. Recent research has evaluated the pharmacologic and procedural and implementation strategies for the management of postpartum hemorrhage. So there's a lot of discussion today on the various things that lead up to hemorrhage, and so what I wanted to choose today was to look at the recent research in the last 2 years that have evaluated the management and pharmacologic interventions that we can take to minimize the hemorrhage. And so we looked at various systematic reviews and meta-analysis and scoping reviews that have looked at the diagnostic accuracy tests for postpartum hemorrhage, how is TXA come into play, the transfusion of blood and blood products in postpartum hemorrhage, if intraoperative cell salvage is beneficial, the effectiveness of the care bundles that you've heard of discussion, and then the recent add of the increasing experience of the placenta accreta spectrum. So time is of the essence, as we've heard, into diagnosis of hemorrhage. And for those of you that don't practice regularly in obstetric anesthesia, our primary hemorrhage is greater or equal to 500 mLs in the first 24 hours for a vaginal birth, or greater than or equal to 1,000 mLs within the 24 hours of a cesarean delivery. A Cochrane review by Eunice et al. Evaluated the diagnostic tests for identifying primary and severe postpartum hemorrhage in vaginal births. And what they saw is when you look at it, our visual detection is what most clinicians utilize. However, we know that adding volumetric and gravimetric measures may be beneficial, but these still don't show a great deal of sensitivity. And so where we see the best combination is using calibrated drapes and clinical observations in combination and not relying. We find that the gravimetric weights and what we use with the quantitative blood loss is more a confirmation of maternal hemorrhage as opposed to an early recognition of it. And using the calibrated drapes and our clinical observations will allow us to enable timely detection of it and then facilitate our care with it. As Dr. Main said, it's the delayed diagnosis and then the delay in treatment. I review several of the maternal obstetric anesthesia closed claims, and what I saw frequently in the maternal hemorrhage cases is you could look at the anesthesia record or the PACU record and clearly see the declining vital signs. However, there was the denial that hemorrhage was the cause. It may have been attributed to the anesthetic or to nausea and vomiting that may be happening, and saying that the change in vital signs were related to that, and not really that the underlying hemorrhage was happening. They also looked at hemoglobin, our shock index, and then the early warning signs. They found that the hemoglobin, again, was confirmation and not early detection, and that you should be using your clinical signs and your measurements to guide care. The shock index is very helpful. However, it's not typically integrated into our standard vital sign monitors. And so again, it ends up being a detection of deterioration and not an early recognition of it. The other item that's been in a lot of discussion over the years is the inclusion of TXA, and the evidence has been controversial. Some studies show that it's beneficial, some studies show that it is not. This recent meta-analysis of Cochrane reviews demonstrated that in low-risk patients who are low risk for postpartum hemorrhage, that TXA prophylactically is not beneficial. This was supported by the women's trial. There were 2 different Cochrane reviews done both for cesarean section and for vaginal deliveries, and then there was an individual patient data meta-analysis, and they did not demonstrate that prophylactically administering TXA would be helpful. A systematic review and meta-analysis, though, on the use of prophylactic TXA in cesarean delivery did show benefit in the patients who were at high risk. So it is not recommended to administer in every cesarean section, but for those patients that are high risk for postpartum hemorrhage with that. And if you're going to administer it, it is recommended to give at skin incision and not wait to give it at cord clamp or after the birth. Also, it noted in that particular Cochrane study that giving the patients prophylactic TXA in the high-risk patients did also decrease their need for blood transfusions with it. The next thing that the Cochrane review looked at was transfusion of blood and blood products for postpartum hemorrhage. This particular study had 12 studies included in over 17,000 patients. Unfortunately, the data really was not conclusive and able to give specific recommendations, and so further research is needed in this area. One of the items that is discussed is the use of fibrinogen or cryoprecipitate. Again, unfortunately, the evidence didn't show conclusively that replacing either with a synthetic fibrinogen or cryoprecipitate can be helpful. Intraoperative cell salvage for those patients who are high risk, is it a consideration to use cell salvage instead of using the allogenic blood transfusion with it? The thought was that if you use this, we would be able to decrease, again, that allogenic blood transfusion with it. And what they did notice is that the confidence interval was so wide when you compared cell salvage to the standard care that they were not able to show that it gave significant benefit with it. Certainly in our patients who are going to refuse an allogenic transfusion, such as our Jehovah Witness patients, that would be someone you would definitely want to consider having that available for. The greatest work that we showed that did cause benefit, that was showing benefit in the systematic review, were our care bundles that you've heard so much of this morning. These have definitely shown that care bundles related to maternal hemorrhage do decrease morbidity and mortality with it, and that it gives you multiple coordinated interventions. This particular study aimed for the effectiveness and safety of postpartum hemorrhage prevention and/or treatment. So the first ones that they highlighted in the prevention was a comprehensive nursing intervention trial. With this one, the interventions that they did were thermal insulation measures, lower limb barometric pressure, encouragement of early mobilization, and postoperative psychological counseling. It was low evidence, but they did feel that it possibly could reduce blood loss, cause shorter hospital stays, and also help with the patient as far as decreasing depression and anxiety and improved maternal satisfaction. There was also the placenta accreta package that was started for preventative. This, they did preoperative vaginal packing, intraoperative uterine circular suture, and ligation of descending branch of the uterine artery. And this evidence was low, but again, possible reduction in mean blood loss, shorter hospital stay, and shorter ICU stay. The treatment-only bundles, when emotive, what was highlighted, but what was interesting about this particular treatment bundle is in most of our bundles, it's recommended to recognize in a vaginal birth that greater than 500 mLs is when you start intervention. In this particular bundle, they actually triggered it at 300. And because they triggered it at 300, they did show a significant decrease in postpartum hemorrhage, decrease in morbidity. They showed decrease in blood transfusions. The mean overall blood loss was decreased, and they had an increase in detection of postpartum hemorrhage and an increased adherence to treatment bundle. And I think that's really key because what we see is that it isn't recognized that it's a hemorrhage. So when you lower that number to 300, it already gets the clinicians being much more attentive sooner. So I thought this was a really interesting one to keep kind of in the back of your head with it. Certainly, another one was a combined management plan for women undergoing cesarean delivery. And normally for the more aggressive treatment options, including a balloon tamponade or thromboelastic guided coagulation therapy, the normal is kind of around a 2,000 ml blood loss. In this particular one, they looked at it at starting those interventions at 1,000 with that, and they did see an overall reduction in mean blood loss. The one that they saw the most improvement with, which is not a surprise after what you've heard this morning, was with the California Maternal Quality Care Collaborative. Those guidelines definitely, after that review, the Cochrane review, did show a significant decrease in severe maternal morbidity. And as Dr. Main mentioned, it's really making sure that the unit is ready, that they're able to recognize and prevent hemorrhage, that they have an adequate plan for response, and the reporting systems. And the benefit of having having this in the Joint Commission accredited hospitals has really spurred the movement. So it has showed that that is the most beneficial kind of care bundle we have right now. As we heard, unfortunately, placenta accreta spectrum, that condition is significantly growing. It's increased from 1 in 30,000 patients that we saw in the 1930s, and I have to say I haven't been practicing since the 1930s, but certainly early in my career, I did not see a placenta accreta spectrum. And now in my practice, it's a weekly event. At my beginning of my practice, I maybe saw one a year. And so that incidence has gone up dramatically. The reason that it's gone up partly is we know is due to the increase in cesarean delivery. And that's one of the reasons you see the bundles trying to minimize cesarean delivery in our patient population with it. With these patients with placenta accreta syndrome, they do have a significant increased risk for hemorrhage and worsening maternal outcomes. They have noted in the studies over the years that if these women deliver at a tertiary care center with a multidisciplinary team, they will have lower their risks for large blood transfusion, second surgical procedures, and composite morbidity. My practice varies. I do work at the academic medical center, but I also work at our community hospitals. And encouraging our obstetric colleagues at times that this isn't the right location for this patient, we need to move them to the tertiary care center. And it's not just about responding to the hemorrhage, it's we know how to respond to the hemorrhage, it's also the consequences that they need the right ICU follow-up afterwards. And our community hospitals don't always have that ability to follow them that well with that. So it has been recommended that there are placenta accreta centers, and as we heard, most of our tertiary care centers do have those. It does encompass a multidisciplinary team, and that they have an intensive care unit and radiologic services available with it, and that they have blood services readily available. ACOG and SMFM, their obstetric care consensus statement, recognizes the perioperative planning that must happen for these patients, preoperative, intraoperative, and postoperative. And it mimics very closely to what we saw in that placenta accreta tertiary care center, with making sure preoperatively we maximize the hemoglobin, confirm the timing of the delivery and the location of the delivery, and then pre-oping that patient appropriately. Certainly having intraoperatively the surgical expertise and having cell saver available and point of care testing and the right equipment with it, and then postoperatively who is going to be managing that care and making sure you have critical care services. What was interesting in the scope, there was a scoping review done for anesthetic management for patients with placenta accreta. And there were 62 studies in this scoping review with it. Only 4 of the studies really had a multidisciplinary procedure protocol that was listed. And it's really important if you're going to be managing these patients that you do have some type of protocol for your facility. Of the 62 studies, I found surprising that only 40 of the studies actually specifically mentioned anesthesia providers in their multidisciplinary team. I just assumed that would happen. So still, again, working with some of our colleagues to recognize that anesthesia providers, it's important that we're involved in the plan of care. There was not, with this scoping review, an overall recommendation of a particular anesthetic, whether it be neuraxial anesthesia or general anesthesia. Depending on what the interventions are going to be surgically, that may change. Certainly, as you can imagine, if an anesthesia provider is part of that multidisciplinary team, they did note that neuraxial anesthesia use was much higher with that. There is still limited guidance on optimal fluid and hemodynamic management, postoperative care strategies, and blood management and outcome reporting with that. It is recommended that anesthesiology be part of the involvement in this team with that. So key insights into the scoping, kind of what to look forward, what we need to do forward. It does require strategic planning and coordination, and best outcomes are seen in our multidisciplinary teams. The current evidence of there's various approaches to anesthesia, and a lack of interventional studies limits the definitive guidance. So there needs to be, in our future research, optimal anesthesia mode to determine what that is, the best role, and the role of advanced monitoring technologies, our goal-directed hemodynamic and fluid management, and then structured blood product and hemostasis strategies, and the best practices for postoperative care. So with that, I think the goal of today is knowing that together we can make a difference, and just being aware of the current evidence that we have available to us and incorporating that regularly into our practice. Thank you.
Good morning. Well, you've seen on all the various maternal morbidity and mortality slides venous thromboembolism, VTE, so you couldn't get to the break without talking about it. So that is what I'm here to do. So today we're going to talk about the problem, the solution, the impact, both the intended and unintended consequences, and then what are the knowledge gaps. So, in all of the various different explanations that you've seen of maternal morbidity and mortality, we've seen that venous thromboembolism is high on the list. This is the 2023 CDC statistics, and you see that venous thromboembolism is high on the list. And this is not a surprise. We're talking about mostly venous disease. We're talking about mostly VTE, about a quarter is PE, and pregnancy is certainly a very high-risk time. The pregnant woman is 3 to 4 times or 5 to 6 times more likely to get a VTE than the non-pregnant woman, and there's a 4-fold increase with cesarean versus vaginal delivery. And pregnant women are certainly predisposed to this. It's sort of like a perfect storm. You have venous stasis, you have pelvic vein compression with the gravid uterus. You have changes in pro and anticoagulant factors, platelet signaling, and just about everything else that you could imagine. When you think about risk factors for VTE in the general surgical population, there are good risk scores, and you get a pretty good idea of who to treat. This is in a very good review article that is a compilation of various different studies that looks at risk factors in the pregnant population. And I don't expect you to be able to read every single one of these. But what I'll tell you is a couple of things. First of all, the data isn't great. The associations are often fairly weak associations. Second of all, there are certain different categories that you might expect: maternal characteristics, pregnancy characteristics, delivery characteristics. Certain things come up over and over again. High BMI, particularly in the setting of antepartum and immobility. Things like preeclampsia, things like delivery characteristics when you get an infection with a cesarean delivery or a vaginal delivery. One thing that does come up over and over again, and is really highlighted in one of these bundles that you've heard so much about, is that risk assessment is not a static entity. You need risk assessment before pregnancy, if you're hospitalized as a pregnant patient antepartum, if you have a peripartum event, and then postpartum, again, risk assessment for VTE. So what is the solution for this? And by the way, this is a problem. Certainly if you have a PE, you can die. But even if you just have VTE, you can have post-thrombotic syndrome and major morbidity as a result. A lot of our solution has been driven by the UK. And I'm purposely showing you a truncated diagram now. This is the EMBRACE data, the triennial reviews that you saw from Elliott Main, and they are looking at the UK maternal morbidity and mortality. And what you can see by these green arrows are two naders in morbidity and mortality from VTE, 2006 to 2009 and 2012 to 2014. What happened during these times? Really what happened was attention on thromboprophylaxis. And everyone was watching when this happened. What was done? Well, mechanical compression boots have been around for quite a long time, but there are some problems. First of all, people don't use them consistently. They're annoying, and people tend to turn them on and turn them off, and even those of us who still use them as part of postpartum, particularly post-C-section thromboprophylaxis, know that they're not used consistently. There's not a lot of data on these, but the data that does shows that you actually have to keep them on. So what the UK did was focus on pharmacologic thromboprophylaxis, particularly heparin. Now I'm going to take you to the right-hand column to low molecular weight heparin, because that's where most of Europe goes. And you can see that that column is a lot longer. Why? Because it's ease of administration, better bioavailability and safety profile, more predictable dosing, lower incidence of heparin-induced thrombocytopenia, perhaps fewer bleeding episodes, and we'll talk in a few moments about the data on that, and lower incidence of osteoporosis. We in the United States, particularly we in the anesthesia community, have a bit of a penchant for unfractionated heparin for a couple of reasons: shorter half-life. We talk about protamine for urgent reversal, but it's not really indicated or recommended for neuraxial anesthesia use. So what are the recommendations that came out of the UK's experience? Well, the Royal College of Obstetricians and Gynecologists had recommendations, and then they revised their recommendations. And then the American College of Chest Physicians also had recommendations, and as did the American College of Obstetricians and Gynecologists, as did the California Maternal Quality Care Collaborative that we heard about from Elliott Main, and did the Europeans, and guess what? They were all different. There are many articles about how different all of these guidelines are. I still like this one, which is almost a decade old at this point, because this took the same 293 women postpartum after C-section and said, what would these guidelines suggest as to whether or not to do postpartum thromboprophylaxis? And these are the percents of these same women who would get postpartum thromboprophylaxis. 85% ARCOD, 35% chest, and 1% ACOG. So what does this all lead to when you talk about the impact of what we're doing? Well, I showed you this graph before, and this is the graph now. This is the latest triennia in the EMBRACE UK data. Not what we hope to see. And they are really good at this. They, by and large, have one set of guidelines, unlike ours. Back originally in 2014, when Cochrane did their meta-analysis and systematic review, and we know that the Cochrane reviews are almost always say insufficient evidence. They said, in fact, insufficient evidence of the current practice of thromboprophylaxis for VTE to show that it had an effect. Fine. So now we have an updated systematic review and meta-analysis from just a couple of years ago. The current literature provided an insufficient sample size to conclude whether postpartum VTE rates differ between those exposed to postpartum pharmacologic prophylaxis and then those unexposed. And this is in part due to the fact that although it remains a significant cause of maternal mortality, it is still a relatively rare event. And all of these different protocols are really contributing to the fact that it is really hard to tell what is making a difference and what is not making a difference. This is some trend data in the US from some administrative data sets. Just to orient you, the top is for DVT over time, the bottom is for PE, the red is for cesarean delivery, the blue is vaginal delivery. What do we see? This is taking us to relatively contemporary data. We see perhaps a decrease in the incidence. This is now per 10,000 deliveries. The UK data is typically per 100,000 deliveries. Perhaps we're seeing a decrease in the rate of DVT for cesarean deliveries up above, not in vaginal deliveries, and we look at PE, if anything, an increase in both for cesarean delivery and vaginal delivery, despite our best efforts. So what's going on? Well, we'll see in a minute we have increasing risk factors. That's not helping. We've talked about increasing mortality overall, and these underpowered studies looking at heterogeneous populations. This is a nice study, elegant, about prevalence of postpartum venous thromboembolus risk factors in an Irish urban obstetric population. A couple of things came out of that. A contemporary view, this is 21,000 consecutively sampled women, a contemporary view of some of these risk factors that we're talking about. Certainly overweight and obesity, age greater than 35, and cesarean delivery, which has always come out as a risk factor. And then I will show you this next part pictorially, but 3/4 had at least one risk factor, more than 40% at least two, and a fifth developed risk factors peripartum. And this is what this looks like. So in the green are the patients postpartum who didn't have any risk factors. In the red are patients who just actually manifest their risk factors postpartum. And in the yellow, at least one risk factor. And remember, these risk factors are increasing over time. What is the unintended impact of all of this heparin and all this treatment and all of this variability? Well, obstetric bleeding. I have to say, I of course reviewed the recent literature for this talk, and it's really hard to get a handle on bleeding, and I see Elliott shaking his head. Some say yes, some say no, some say heparin unfractionated is worse than low molecular weight. Heparin, a recent multi-center cohort of 17 hospitals, fairly contemporary, showed that postpartum thromboprophylaxis was not associated with bleeding complications. And needless to say, it probably depends to some extent on the dose and how it's used. Since we are, many of us, anesthesiologists, I have to spend just a few moments on anesthetic bleeding and what we worry about. This is a picture of a spinal epidural hematoma. Now, in general, and this is just a summary of some of the largest studies, we are lucky. Obstetric patients are at extremely low risk for spinal epidural hematoma, on the order of 1 to 200 or 250,000, unlike an elderly surgical patient who could be as high as 1 in 3,600. We did a pretty extensive review of the literature to see whether patients getting thromboprophylaxis, low dose, had an increased incidence or actually number, because we don't know the denominator of spinal epidural hematomas. We did not find any cases of patients just on low-dose thromboprophylaxis. There were a couple of cases where there were confounders. And we also looked at the closed claims data that were available to us. No cases just from low-dose thromboprophylaxis. This is an updated literature review, very similar, and both cases there were confounders. One had multiple attempts, which is typically thought of as being a risk factor in and of itself, and another had multiple anticoagulants. The details were not enumerated. That said, we know that there's underreporting. So just a show of hands out of curiosity, how many people know of patients who you found out afterwards had a neuraxial anesthetic with an anticoagulant on board actively? I certainly do. And how many people actually know of a complication that was associated with it? I have to say I do too in a non-reported case. So we can be comfortable that this is not wreaking havoc, that we are not having a rash of spinal epidural hematomas, but the issues are probably more than are actually reported. Again, we have evidence, although incredibly scant evidence on incredibly small numbers of patients, that our obstetric patients metabolize and process, and the pharmacokinetics and dynamics of these medications in pregnancy are different. This is one of the famous tiny little studies on 6 patients, pregnant, 6 patients who weren't, who got unfractionated heparin, about 9,500 units. And if you look at the upper graph, that represents the plasma heparin concentration on the left and the APTT on the right, of the non-pregnant on the top versus pregnant on the bottom, an attenuated effect. And this next study was for enoxaparin, a single dose. And again, I will raise your, on the left, the vertical axis is anti-10A activity. The horizontal axis is time. Above is non-pregnant. Below the darker blue line is pregnant term, an attenuated effect. I will just point out here that the new ASRA guidelines talk about a threshold level if you're going to check anti-10A levels of less than 0.1. These values are not less than 0.1 for any of these patients at the 12-hour mark for this low dose. I digress, but I thought you'd be interested to see. So it was important for us all to get together because all of this is happening and we're all doing it separately. So we brought together with SOAP, not only our ASRA colleagues, but our OB colleagues in SFM and ACOG and ASH, and together we made guidelines to do a couple of different things. One was to lay out what we're not going to go through in detail now, but were the elective best case time delays based on half-lives and to some extent influenced by case series and reports in non-pregnant patients for unfractionated heparin and for low molecular weight heparin between a dose and when the patient could have their neuraxial procedure. Probably more importantly for this group, we with ASRA agreed that our pregnant patients, whereas we probably couldn't make a whole set of guidelines that were different, we definitely needed to have discretion with our pregnant patients, that the risks of not doing the procedure were different than in the general population. There needed to be discretion and a different weighing of risk and benefits. And of course, always with any recommendation, it is not a legal precedent and it does not replace clinician judgment. Probably the most important thing about the guidelines, and still to this day, is that we need to plan and we need to work together. We need to know which obstetric guidelines we're using on our labor floors, and we need to know which patients are getting what. Everyone should be on the same page about what the time interval wait guidelines are, because they are the same now, really, SOAP, ASRA, ESA, all the different organizations. We need a way to identify patients who are on these anticoagulants, ideally flags in the EMR, ideally the question at a timeout, even for a labor epidural. And there need to be discussions and protocols for when patients who are on anticoagulants call in to say, I think I'm in labor. What do they do? The expected circumstances are one thing, the unexpected are others. I will say that in Europe and more in the US, people are not bridging with unfractionated heparin. The patients are more and more on low molecular weight heparin. We do not have data how well it's working out. It seems to be okay, but it would be wonderful to have data. So let's get back to VTE to finish up. What are we going to do with this morass of using heparin, not knowing if it works? Well, there are two studies that I think are going to be really helpful to us. The first is called the HILO study, which I have been following for years, since the protocol first came out. This was a very large open-label study that was specifically looking at, in high-risk patients who had had a VTE, is it better to do larger doses of heparin? Because we know that some places and some patients get low dose, which is one thing for us, and others get weight-based dosing and such that means a whole other set of things in terms of much longer wait times. Often in low molecular weight heparin, the difference between 12 and 24 hours. So which is better? This study published in The Lancet, 70 centers, 9 countries, contemporary over the last almost decade, 13,000 patients, looked at both VTE and bleeding. VTE occurred at about 1% in both the low dose and the intermediate weight-based dosed heparin prophylaxis. There was about 4% major bleeding, as they called it, in both groups, so no difference. And they concluded there is no reason to use weight-based. That was their conclusion. And then this study, which at this point is a feasibility study, they wanted to say, is it actually possible, given the variability in practice, to be able to do a definitive study as to whether this heparin prophylaxis is actually working? And we don't have to go through all the details of the study, but basically they showed that they were able to do enrollment and randomization and follow-up, 3-month follow-up, at a rate that was better than they predicted. They exceeded expectations. Of note, for this small pilot, they saw neither major bleeding nor VTE, but it is just a pilot. And this will hopefully be the next study published in The Lancet, and I'll have a different talk the next time I come to talk. So we have remaining knowledge gaps, and I'll go through them quickly. Validation of the prediction tools in terms of absolute risk for individual patients. The optimal risk threshold at which we should initiate thromboprophylaxis in the first place. the optimal dose, although I think high-low study perhaps gets us closer, the optimal duration of therapy, the bleeding risk. Is it something we have to worry about? And the impact of expanded thromboprophylaxis on what so many of us do, obstetric anesthesia. This is just a little chart I will conclude with that is from a recent opinion piece in the British Journal of OBGYN in 2025. And it basically, in summary, says they suggest about a 1 to 2% risk tolerance, and antenatally and postnatally to use some patient decision-making, shared decision-making, which is, of course, the buzzword now, but at least when you're talking to your patients, let them know of the data. Let them know that this is not something that is ironclad. And absolutely, let's get some good data. So I thank you. I look forward to all of your comments in the discussion section.
If we could have all four speakers come up to the dais, we're going to have the opportunity to address questions since we're fully ahead of schedule. And I'm sure every topic was perfectly covered except for the last one. While we're gathered, let me just start with Lisa. I would have to say that VTE was the most difficult challenge for CMQCC by far, and because the lack of data was just, lack of good data was really overwhelming, and we were very disappointed in the UK and saw just tremendous overuse of heparin or low molecular weight heparinoids. And we were also dismayed by the continuing maternal mortality reviews that showed a lot of the maternal deaths were early in pregnancy, even at 6 to 8 to 10 weeks of pregnancy when estrogen spikes and before they had gotten prenatal care. So we're flummoxed with what to do for VTE. And I think your talk perhaps raised more questions than answers at this point. Where do you think we should be headed? Or was that the very last slide that you showed, I think was?
I'd love to say, Elliott, that I could figure out what you couldn't about obstetrics, but that would be presumptuous. You know, I think you said it well. It's very, very tempting to get on board and want to fix it. I think we're all fixers, but I think this is an important moment to realize that doing something is not necessarily always the best thing, and taking a step back and organizing ourselves and trying to, if we are doing something, trying to do something more uniform, more thoughtful, and maybe a little bit less is more is the way to go at this point.
Questions out there? Please. Oh. So please come to the microphone on your left.
Hello, thank you panel for your presentations. My name is Mike Olympio. I'm from Wake Forest University, retired. And you know, I've been out for quite a while, and what I'm happy to see is that the regulatory authorities are either implementing, mandating, or recommending the toolkits, the guidelines, and all, with all the evidence that they're very effective. But What I haven't seen is that they're mandating or requiring that somebody be named as the champion or selected as a champion in a particular institution. And the reason I say that is my career was in academics, and in academics we all want to learn what the guidelines are and publish what the guidelines are. And then I worked in private practice at the end where I learned that people just want to know what they are and tell me how to do it. Just tell me the answer. I don't want to read the literature. Just somebody tell me what to do. And in my experience, people are shy, they're humble, they don't want to step up, they don't want to make a scene, and so these guidelines do not get implemented in private practice. So I'd like the panel's opinion on whether the regulatory authorities should specify that somebody be named with a name at the institution for implementing this.
Thank you for a really important point. This is really the issue that I mentioned at the very end of the last mile issue. What happens at the hospital? What happens at that final stage of implementation? It's interesting as CMS is unveiling its birthing friendly initiative, which is asking each hospital to say if they have implemented the bundles. So that's the question. How do you measure that they've implemented the bundle? And we're thinking of coming up with a variety of steps, including having a champion that's designated. So to implement a bundle, you have to do 1 through 5, let's say. And that's going to be a step. That's still under development, but I think that's kind of what's needed. But clearly a champion who has responsibilities is a key step of it. Others, please.
Thank you for your question. I agree having a designated person would be very helpful. Again, working in a large tertiary care center and then working in smaller community hospitals, it is very different. I was very hopeful when the Joint Commission administered those guidelines that they had to meet for hypertension and hemorrhage. But what I have found disappointingly is our academic medical centers are implementing them and doing their simulations, and they're very aware of what the protocol is. I'm not seeing it in our community base as well. And part of the problem for us as anesthesia providers is in our community hospitals and our smaller hospitals, there's not a designated OB provider, anesthesia provider. They're covering the main operating room and they're covering OB. And so OB does not become their priority in that they need to keep up with these protocols and guidelines. And so I like your idea of having a designated person and having our cognitive aids on our maternal hemorrhage carts and making sure that someone is really following the cognitive aid and calling it out, because our anesthesia colleagues that are not regularly on the OB floor, it is not second nature to them. I think all of us could spit off the protocol very quickly. But if you're only up in the OB unit on a hemorrhage scenario, once a month, maybe once every couple months, it doesn't become ingrained. And so I do think we need to find a way to really encourage having that champion there at the moment to follow the cognitive aid.
I'd just like to add to Beth's comments. Not only do we need a champion at a hospital, community hospital, but we need an anesthesia champion. And to be able to designate both, I think it's going to be a key step. Next.
Thank you so much. Great talks, all of you, this morning. I'm Meg Rosenstein. I'm the Director of Obstetric Anesthesia at a small hospital, Overlook Medical Center. We're part of Atlantic Health System in New Jersey. We are an intensive community perinatal center. And Jen, my question really leads to your topic. Actually, a couple weeks ago, on my way home from my flight in Chicago, I got a quick ping from a non-obstetric anesthesiologist, a generalist. He's actually fellowship trained in pain. He was covering the labor floor that day. And something wasn't sitting right with him, and it was a mom who had developed a peripartum cardiomyopathy. This was a mom who had been with us for an extended period antepartum due to gastroparesis. She had had a pretty troubled course, and she was starting to have tremendous lability in her blood pressures and starting to decompensate. The team of obstetricians and perinatologists had pulled together a plan moving her towards delivery, and we were a little late to being included in that conversation. Jason knew it didn't sit right, reached out to me for my advice. We really quickly, as soon as I was off the plane, pulled together a collaborative team, exactly the model that you're talking about. And that patient that you referenced in the beginning of your talk was exactly my fear for this woman. We were wholly underprepared. We are not a cardiac center. We're affiliated with one, quick helicopter ride or a 15-minute highway away. How do we, in a community center with limited cardiac resources, make sure that we have that early seat at the table to minimize the just-in-time planning for potentially critically ill patients for transfer?
That is why we're here. I mean, I feel the same way. I'm like, even when I felt like we consulted cardiology for that patient, and they were like in a different, they were scared because she was pregnant, right? We had to get over the fact that most cardiologists don't want to take care of pregnant patients. So once you get past that, like you said, okay, you're there, you're trying to get involved, but maybe you have to transfer the patient to a different hospital. That's where we're in trouble. Like, I don't know the better option. I think our fragmented care is really the biggest issue. I feel like if we could fix that in all of healthcare, we would fix everything, but that's what I think we should be focusing on tomorrow, is to figure out, like, how do we do a better job of, like, this patient needs to go to a different center, how do we get her there? If we need to have, like, you know, the cath lab ready to go, how do we talk to them so we're ready? If we need different drips, like, yes, we know how to handle this, but these are really complicated patients. I think that's the problem. When I wrote this talk, I'm like, there's nothing for me to say except, like, do your best. Like, my punchline says nothing because I don't know the answer to that. I think that's what's so frustrating about cardiac obstetrics. There's, you know, do your best, hope for the best, consult the right people, be multidisciplinary. Like, those are kind of weak responses, I feel like. Like VTE, we're like, okay, we know a plan. Let's, like, give them something. I find it very frustrating. I wish I had a better answer. I don't know if someone else has something better to say. I agree with you.
It's a great answer. We'll try to all fix it together.
You know, I think one of the key issues, though, is what to do with a postpartum woman who's tired and short of breath. How do you evaluate them? And as a start.
One of the little things, which sounds really, like, simple, but I think has been very helpful, is yes, we're doing POCUS a lot, but really getting formal echoes on these patients who we're, like, a little bit suspicious of. And I almost think, like, I can't believe how many things we catch. I'm like, should we be doing it in everyone over a certain age? Or should we be doing it in anyone over a certain BMI? Like, who should be getting these echoes? I mean, we can't do it on everyone. It's cost prohibitive, but I have a very low threshold to do POCUS and get an echo. And I think that has helped a lot, but.
And Jennifer, can you expand on the use of ProBNP as a screening tool for these patients?
Sorry, I missed the very beginning, you said?
Can you talk about the use of ProBNP as a measure, as a screening tool for who needs more intensive evaluation?
I didn't hear this.
Sorry, it was just about the ProBNP, how that can be used very, very
Yes.
well along with symptomatology.
So right, we're into, the problem with BNP though is that you really need a trend in pregnancy, right? It's not super helpful isolated. So BNPs can be very helpful with echo. ProBNP is supposed to be better, but it doesn't help you unless you know where it's going. So if you're the first time to see the patient decompensating and you get your BNP, yes, if it's super high, you know it's a problem, but if it's just kind of borderline, it doesn't help much. So I think if it's borderline, we can use that to do echoes, to do our POCUS exam if you have access to ultrasound, although a lot of institutions, especially our rural hospitals, don't have that. That's a luxury that I know we have. It's hard, right? I don't know if you want to add something else, Jill, about it, but I don't find it, we do it a lot, I don't find them super helpful.
Afshan Hamid.
Jennifer, do you mind if I comment on that just a little bit more? So sure. I think there's a couple things that are really key with cardio-obstetrics, and number one is identifying heart failure, because women who die are often dying of heart failure. Yep. And the single simplest message is if a woman comes in with a saturation less than 95%, she needs to be ruled out for heart failure. That's number one. Number two, BNP. If the BNP is normal, then it's probably not cardiac pulmonary edema. So that's your like step one, step two, and then follow it from there. And then the last thing is from an anesthesia standpoint, their ability to lie flat with heart failure determines your anesthetic. So if they cannot lie flat, then they need to be diuresed to the point that they can lie flat, allowing you to do your regional anesthetic. If they are unable, if when you need to go, they're unable to lie flat, then you need to do a general anesthetic because that pulmonary edema is only going to worsen at the time of birth. So anyway, those are kind of my, as far as the BNP is concerned, I think it is helpful when you're in that lower saturation, can't figure out undifferentiated state.
I think the problem is when their vitals look okay. We're just starting right at the beginning. Already, if you're desaturated, like I say, we should never be. Sorry. I agree with everything you say and more, but I think that the problem is that if they're already desaturating, it's already too late. And so I think part of the problem is we'll have someone who's like 94%. I'm like, we better be at the bedside if they're 94%. You better have someone from anesthesia there because you are not ignoring even a subtly decrease. And anyone's on oxygen, you should be really worried. I mean, that is your time. Even if they're hanging around 92, that is concerning. That number is no longer normal. So I agree with everything you say, so thank you.
Hi. Well, I know Dr. Main very well, but my name's Courtney Martin. I'm an OBGYN with critical care experience and have worked on a fair amount of the toolkits and on the PAMR committees from California. I wanted to make a few comments from the perspective of a general OBGYN who still takes 24-hour shifts and does, a lot of quality improvement and change management. I was also the chief of quality of a children's hospital, so I love that the overlay between children and obstetric patients. It's very similar for those of us who have taken care of patients who are children and women. But I wanted to comment a few things. First, I'll jump to the pro-BNP. I would let you know, as an OBGYN who has so many patients coming in with symptomatology that can be arguably what everyone wants to say is normal for pregnancy, the pro-BNP in an outpatient setting or in an obstetric emergency room can be helpful for us as the obstetrician to order because, again, if it is completely negative, then I'm working up other things or I'm thinking maybe this isn't essentially cardiac, but I appreciate the comment about trending, absolutely. I wanted to make the comment that Elliott knows well my passion for this community, which is a wellness bias that we see, and it's really relevant to cardiovascular disease in pregnancy and sepsis. So the wellness bias is a term we've sort of coined, which is that everyone, maybe not in this room, but many people in all other fields of medicine and in this country still think that pregnant patients are young and healthy. And we know that's not true. So really understanding how sort of normalization of vital signs and actually just not even understanding vital sign differences in pregnancy physiology is really important. So as far as the wellness bias and vital sign abnormality and the comment about implementing change, I would interested in the panel's opinion on education and extensive education on maternal physiologic changes and how that looks clinically when we're trying to identify sepsis, hemorrhage, cardiovascular disease. And what I mean by that is trying to campaign at your institutions to develop noise around, do you know what an ABG should look like in a third trimester pregnant patient? Do you know what we're looking for, why we should be more concerned with someone who's had a coarct repair when they're coming for delivery? So any comments on that wellness bias, how maybe you guys are facing it or trying to address it at your institutions regarding these things?
So I think that's a great question, and as someone who does practice both critical care and OB anesthesia, it's really interesting to me that a lot of my intensivist colleagues have a hard time remembering what normal vitals for pregnancy are, recognizing it's abnormal in a different way than my obstetric colleagues. So I'm not exaggerating that I have printed the CMQCC algorithm because I think all of these, it's not just one vital's abnormal or different than normal. You can say, here is this woman's vitals labs, and here is a list of things that are abnormal, and she's meeting a couple of them. You only have to meet a couple to actually trigger the warning, and it helps break down. I mean, I had a woman in septic shock who they were asking me to disconnect the epidural to get a CT PE, and I said, well, let's look at her. Yes, she's tachycardic to the 170s, and they knew that was abnormal, but she also has no urine output. Her white count is 20, and yes, she doesn't have a fever yet, but please don't send her to the CT scanner like this, right, for antibiotics. And having an objective tool to talk around that is super helpful. In terms of, I think there are so many things that are normal for pregnancy. The baby's blocking there's some reason that there's no urine output despite 3 liters of fluid. It's the baby. And the reality is if you have a tool that is designed by obstetricians and anesthesiologists and nursing and everybody together, it's harder to say it's me telling you you're wrong or you telling me I'm wrong, but let's step back and really look at our patient against this awesome tool that exists that is free. So I think that's one of the reasons I find these tools so helpful is it's just objective. It's not opinions. It's looking at your patient, their data, with something designed by people much smarter than I am.
My favorite is tachypnea is normal in pregnancy. That's never true.
Yes.
Right? Remember?
Yeah.
So, yeah, a 26 respiratory rate's a problem. You don't get a physiologic increase above normal. And so things like that, subtle things, really pervasively integrate in healthcare systems, and that's why we miss those early signs, for sure.
That's assuming it was recognized, which is a
So
whole...
we have 4 minutes left, so we'll quickly do a few more.
Hi everyone, my name is Neil Ray from Sacramento, California. What struck me about these 4 conditions that we just talked about is they all have one risk factor in common, and that's the cesarean delivery. We all know that cesarean deliveries are life-saving, but we also do too many of them. It's 50% have been estimated to be medically unnecessary. So to me, it seems like if we really want to get a handle on embolism, sepsis, hemorrhage, cardiomyopathy, we should talk about reducing C-section rates.
That has been one of our focuses in California, and we have a toolkit and a big state collaborative that has reduced the first birth C-sections. The problem is that we have this hangover of so many prior C-sections out there. So I'm not thrilled with the ARRIVE trial that seems to be encouraging inductions, and which is probably leading to more C-sections. But that's a current work, and I think we all have to identify that C-sections are not risk-free. So thank you for that. Next.
Yeah, I'll be quick. Thank you for your great talk. So Chase Sims, Mayo Clinic in Rochester. I'm a critical care anesthesiologist by training, but I'm also chair of quality at our hospital, working very closely with the hospital practice on sepsis improvement. And September is Sepsis Awareness Month, so happy sepsis awareness for everybody. But my question is to this group, we've been working on the ED, the ICU, the general ward floors, but I haven't even thought of the OB unit. And Courtney Martin and I were just talking about, you look at choreo, for instance, that's going to be very hard to get source control until the placenta comes out. And so we're building this because we have a sepsis problem even in Rochester. And so we're in the early stages, we have a blank slate. What would you suggest that we need to focus on, or what's some high-ticket items that we can bring back? I'd love to discuss with you maybe offline as well. But I just want to say also thank you very much for your talks and bringing attention to the problem.
It's a big question to talk about in 1 minute. But I do think recognition that something's not right is the first step. And that isn't only sepsis, I think it's everything, that recognizing something is not meeting the standard in the same way the vitals are abnormal, the labs are abnormal, something abnormal is happening, and accepting that it is abnormal and not writing it off as it's pregnancy related. I don't know if anyone is...
Sure. I think one of the challenges with sepsis 3 is that it requires end organ injury, which is late. And so the issue is early recognition, and we're pushing that if you have abnormal vital signs and an infection, you really, which is not yet sepsis, but you really need to aggressively treat those patients with fluid and antibiotics. So Friday we have a whole webinar on this that you're welcome to join.
Yeah,
Last
actually,
question.
Courtney turned me on to that, so I'll certainly join in. The big question I think we also need to focus on, which you mentioned briefly, is the ambient monitoring in the background, and I think that'll be a big part of what we do going forward, but I may discuss about OB-specific things that we can start looking for as we change those parameters. Thank you.
Hopefully, maybe last but not least, Carol Peden. I'm an anesthesiologist who's held national patient safety roles both in the UK and in the US. And I think one of the themes of the panel, and fantastic talks, by the way, and such an important topic, is early recognition of the patient. One of the things that rarely gets mentioned in the US is that in Europe and much of the rest of the world, pregnant women are primarily managed by midwives. That means they go through a very structured process to recognize risk and escalate, you mentioned Elliott, levels of care. I've never heard a mother in the UK talk about my OBGYN. They talk about my care plan. And I wonder if that personalization, when we've said that so many of these issues are very low numbers, so an OBGYN with a small practice in a small community may never have seen any of these things. So how do we get much earlier back in the process and make sure these high-risk women are seen in the appropriate level of care earlier?
I think the issue is that we need to do this risk assessment and evaluation and consultations long before labor and delivery, during prenatal care. I mean, that's when cardiovascular disease really we have a big opportunity, except for the cardiomyopathy, of course. That's the big opportunities. And with all the comorbidities that we're seeing now, that's really the opportunity to maybe have an impact, is to do evaluations, do a risk assessment prenatally. I'm a proponent of midwives, but there's a big shortage of midwives in this country. So that's a wish list that we're not going to achieve in the next 10 years. But there needs to be a broader workforce for sure. Thank you. How much time do we have left? All done. Okay, we got the poll. Thank you all. Thanks for speaking.
Hi, everybody. I think the talking and the engagement is a great sign. I'm really excited about it. We're going to have everybody please come back into the room so we can stay on schedule. Hello? Oh. Okay. Thanks, everybody, for coming back. I'm really excited by all the talking and engagement that's going on. So everyone here knows that we anesthesia providers can't get enough out of our gizmos and gadgets and devices. And so we thought it'd be really fun to have in the next session a discussion with experts in industry and new technology, and in particular frame the potential for these devices to level inequities and disparities in care, a topic which is really, really important to all of us. So I'm just going to quickly introduce the 4 speakers and then let them come up and do their thing. So the first speaker will be my friend, Dr. Jill Meyer, who is professor and chair of anesthesiology at the University of Arkansas in Little Rock. Among her many respected roles, she's executive section editor for OB Anesthesia for the journal ANA and chair of the SOAP Research Committee. Real concrete evidence of her role as a thought leader in the field of OB anesthesia. And today she'll be sharing her insights as a national expert in OB quality and safety. Next, I'm thrilled to have voluntold my friend, Mahesh Vajanathan, to join us today. I counted on him as treasurer of SOAP, actually, when I was president. And Mahesh is local here at Northwestern Feinberg, where he plays leadership roles in the well-being analytics team, the patient hospital monitoring system, as well as their remote monitoring system, and he teaches about data science, AI, and machine learning. Third, we're so pleased to have Michael Mestek, who is Vice President of Clinical Research and Medical Science for Medtronic, which is a corporate sponsor of this conference, for which we are very grateful. In addition to having a leadership role in industry, he has a faculty position in the Department of Bioengineering at the University of Denver, where he teaches about device commercialization. And the 4th speaker you'll hear from is my friend, and I would say my conference work wife, co-chair of the planning committee, Dr. Meghan Lanefall. She's professor and newly minted chair of anesthesiology at Columbia University. In addition to being an intensivist, she has special expertise in implementation science, and during this session, she will help us think about how the identified challenges that we find can be parlayed into actionable, impactful improvements. So with that, I welcome Jill up to the podium.
Well, thank you, May, and to the Planning Committee for inviting me to be a part of this program. I've not been to the APSF conference before, and I'm enjoying it very much. I was given a challenging topic to cover in 15 minutes, but fortunately, this has been addressed thoroughly this morning by Dr. Main and the other presenters. So my lessons learned will mostly echo what you've already heard, but I've taken a little bit bigger perspective, and we'll talk a little bit more about population health and societal impacts, and just to trigger some thinking about what we can do as anesthesiologists to address them. Disparities have been defined by the NIH as largely preventable health differences that adversely affect populations who experience challenges to optimal health. And this is important. They're closely linked to intergenerational, social, economic, and environmental disadvantage. And it's estimated that just 20% of health disparities trace back to the actual health encounter, the systems of care and response systems that we talked about this morning. And the rest is really attributable to social determinants of health that underline the health conditions that women bring into the health system, but also influence our public policy, resourcing distributions within our society, and the infrastructure and resourcing available in our health systems to create optimal care protocols and to deliver that optimal care. There are 6 racial and ethnic minority populations recognized by the NIH to have health disparities, and also groups with low socioeconomic status, underserved rural populations, people with disabilities, and sexual minority groups. Some of these are easier to study using administrative data, and because maternal mortality and severe morbidity are relatively rare, much of the research relies on administrative data, and so the bulk of the research is really focused on racial and ethnic minorities and some on socioeconomic status, with less research available investigating the other vulnerable groups. Notably absent from this list are immigrants and people for whom English is a second language. Now, those of us who take care of patients know that many people will have multiple marginalized identities, and that those identities intersect in a way that increase risk factors, synergistically increasing risk for adverse health outcomes. In addition, patients will have risk factors like advanced maternal age and obesity, and really it's the intersection of all of these risk factors that determine individual risk for adverse outcomes. Looking at the population prevalence of each of these risk factors, you can imagine that, in fact, it's probably the majority of delivering women have at least one marginalized identity. Now, we've thought about the impact of race on maternal mortality for many years. This is the kind of original slide from 1965 showing the remarkable decrease in maternal mortality in the United States from 1910 to 1960, and you can see the difference between black people at the top and white people at the bottom has been measured from the beginning, and that relative risk has not changed, but the absolute risk decreased as the total risk of maternal mortality declined. So improving outcomes for everyone has the potential to shrink risks if we're improving conditions equitably for all populations. Rates of maternal mortality continued to decline through about 1980 when they stabilized and then started to increase in the 1990s. And we've talked about this peak that happened in 2021 with Delta variant of COVID-19. And US maternal mortality rate peaked, according to the NCHS, at 23.8 per 100,000 and then subsequently declined to 18.6. Which is comparable to rates before the pandemic. For black women, the ratio peaked at almost 70 per 100,000 and then declined to 50 per 100,000. And so the most recent data from 2023 suggests a risk ratio between black and white people of 3.5-fold risk in maternal death. The trend lines for Asian and Hispanic women kind of mirror that for black women, and interestingly, in the most recent data from 2023, their risk of maternal death is slightly lower than that for white women. You should know that in addition to these racial and ethnic disparities, there's also tremendous geographic disparity in maternal mortality in the United States, with California being a leader. They're reporting here a ratio of 10.5 per 100,000 as compared with Tennessee at 41. And you can see that cluster of high-risk states in the South that includes Arkansas, where the maternal mortality ratio approaches or exceeds 40 per 100,000. Now, I sit on the Maternal Mortality Review Committee, and about 18% of the delivering population in Arkansas is Black, 13% is Hispanic. We have large, and it's over 65% are white people. And what's interesting is that the ratio of maternal mortality between Black and white people in Arkansas is only 1.2 for the years 2018 to 21. And outcomes for Black people are really commensurate with the national average. And what's remarkable is this very high rate of maternal mortality among white people in Arkansas. And I think it reflects some vaccine denialism and the fact that this took place during the years of COVID-19, but it also reflects very high risks that we see amongst residents of rural counties in Arkansas. The numbers on this slide are incredibly small, so we have to be careful about overinterpretation, but just a general theme that I see is that mortality ratio in central Arkansas is commensurate with the national average, but all of these rural quadrants of the state have ratios between 30 and 60 per 100,000. And so I just want to bring to your attention the risk of maternal mortality that we're seeing in rural populations. Now, Northwest Arkansas is interesting because it's among the fastest growing metropolises of this country. Benton County is that county at the top right corner. It is in the top 20 most wealthy counties in the country. It is headquarters for Walmart, Tyson Foods, as well as J.B. Hunt. And it's the home for Alice Walton, who's the heiress of the Walmart legacy, and she's world's richest woman, estimated at $117 billion. Interestingly, within 30 miles of her home, there's a community of Marshallese people, about 12,000 people who immigrated from the Marshall Islands to escape nuclear fallout in the 1980s and 1990s. And the U.S. conducted its atomic testing in the South Pacific, and that contaminated those islands. And so this population of 15,000 people live and work in Northwest Arkansas. They are workers at the meat packing plants, and they were among the demographic, or the people who were most impacted by some of the outbreaks of COVID-19 in the meat packing industry. And so you can think that it only takes a couple of those people to have pregnancy-related deaths to impact that region's maternal mortality ratio. And I tell this story just to illustrate that I think going on in America is this widening disparity of wealth inequality that's probably underlying some of the statistics that we're watching. Another issue in rural health is the closure of maternity hospitals. This is from the Obstetric Anesthesia Workforce Survey, which is out, I think, this month or next in anesthesiology. And between 1981 and 2023, you can see a pretty stable total births, not much change there, but a decrease in delivering hospitals from over 4,000 to less than 2,000. And in fact, since 2020, we've lost over 1,000 delivering hospitals in the US. And that has created what has been called maternity care deserts. These are counties with inadequate access to obstetric delivering hospitals, as well as obstetric providers and prenatal care. And as a result, qualitative analyses with residents of rural communities and my own clinical experience suggests that folks put off prenatal care. They do not want to come into the major centers. Even when they get sick, they worry about being admitted and being separated for long periods of time from their families. Many of them have responsibilities at home that they can't neglect. And so we're seeing a delayed presentation of care. So we've talked this morning about increasing comorbidities in the population of people becoming pregnant, and that really sets women up for increasing risk during pregnancy. I was part of this group that looked at racial and ethnic disparities in severe maternal mortality in a nationwide inpatient sample, and analyzed a group of an estimated number of 13.5 million births and found 218,000 cases of severe maternal morbidity. Interestingly, the ratios the rates were increased, looking at the full composite that includes hemorrhage or includes blood transfusion on the left of this slide. But then when zeroing in on severe maternal morbidity without blood transfusion, the risk differences were really decreased. And that suggests that the magnitude of racial disparity reflects differences in blood transfusion. And as Dr. Main said this morning, focusing on anemia in Black women and Native American women, and then focusing on supporting intended vaginal birth and avoiding surgical injury with cesarean delivery may be probably the most effective means to impact racial disparities, at least as it pertains to severe maternal morbidity. This group looked at the premier database and rates of severe maternal morbidity in about 11.5 million people who delivered across 1,200 delivering centers between 2008 on the left and 2021 on the right. And the unadjusted severe maternal morbidity rate increased progressively. You can see lots of bouncing around. And then this spike at the end reflects the impact of COVID-19. And then they did a risk adjustment for comorbid disease that people bring into the pregnancy or non-obstetric complications like COVID-19. And that risk adjustment really smoothed the line out, but you can see there continues to be a steady increase. So there's steady increasing rates of preeclampsia and complications thereof and cesarean deliveries as a result likely of the increasing comorbidities that people are bringing into the pregnancy. They stratified that analysis by vaginal birth and cesarean delivery, so the bulk of the increase. So in 2021, I believe the rate of severe maternal morbidity in cesarean deliveries was estimated at 3% versus 1% in vaginal births. So again, supporting intended vaginal birth, being thoughtful about treating anemia and avoiding blood transfusions, but also when we do cesarean deliveries, supporting timely cesarean delivery and then thinking through antibiotic prophylaxis and getting SCDs on patients and doing all of the safety checks as we go through so that we protect maternal safety even though we're hurrying to get babies delivered is an important part of addressing severe maternal morbidity for this audience. This group also stratified that trend line by race and ethnicity, and they found something interesting. The ratio is increasing for white women in orange and less so for Black women in light blue, but they saw dramatic increases in the much smaller population of Pacific Islander women in cerulean blue, in Native American women. Should I keep going? In Asian women and in Hispanic women. So these subpopulations have rapidly increasing rates of severe maternal morbidity that are not well explored or thoroughly explained in this analysis, and I think we need better data to understand what's going on in those populations. I want to move us along and pivot to use of neuraxial labor analgesia, since it's, that is an area of focus for obstetric anesthesia, and because multiple studies have demonstrated decreased use in both Black and Hispanic women. Interestingly, this randomized trial published in Anesthesiology by Brandon Tagioka showed they had a cohort of 200 women that they randomized between a comprehensive language concordant education program that had both a video as well as an instructional pamphlet, but probably most importantly, they did individual counseling with shared decision making to explore the individual concerns that the patient had and to address them. And they showed that among the 50% of the group that were Hispanic, that intervention increased use of epidural analgesia from 60% to 80%. No difference in the non-Hispanic population, probably because their use rate was already quite high. And reflecting on those conversations in counseling, they were addressing many concerns around trust in the health system, worries about paralysis, and worries about back pain. And so that suggests that underuse in these vulnerable populations is less about empowerment and going after that natural birth and more about distrust in the health system and fear-based decision-making, and that a little bit of extra time and effort from anesthesiologists to address those concerns in specific will close the gap in terms of access to labor epidural analgesia. Jean Guglielminotti and his team was interested in looking at the effect of structural racism on labor neuraxial analgesia use, and this is their theoretical diagram that links through structural, institutional, and interpersonal racism and how the mechanisms by which each of those variables might influence labor neuraxial analgesia rate. And just as an example, one can speculate that in a health system that's relatively under-resourced, there may be less subsidy for the anesthesia group, and therefore the anesthesia staffing is going to be relatively tight as compared with the workload, both on the L&D unit and off the unit. And as a result, the team members are going to be spending more of their time off the unit addressing needs in the main OR, codes, and other responsibilities. And so even though labor neuraxial analgesia is available in that hospital, it may be less readily available when people need it. They pulled data from U.S. birth certificates from 2017. There were 1.7 million certificates that they analyzed, and they applied a validated index of structural racism to the county of where the delivery happened. And that index looked at 3 bad things. It looked at the population rate of those 3 bad things in Black people versus in white people in that county. And when that ratio of incarceration, low education, and unemployment was very high, that was a county that was designated as having the most structural racism. And you can see that that is indeed correlated with reduced use of neuraxial labor analgesia by 28% in Black people and by 15% in white people. So structural racism, it appears, degrades the quality or the ability of institutions to deliver neuraxial analgesia for everyone with impacts that are disproportionate for the most vulnerable populations. And of course, neuraxial labor analgesia is such a useful tool for anesthesiologists because we can extend that to provide anesthesia for cesarean delivery and thereby reduce the need for general anesthesia. And there's evidence from the MFMU network, which is a network of NIH-funded randomized trials in academic medical centers, so best case scenario locations, and even in those settings, there's evidence for increased use of general anesthesia among Black women. Now, this single center analysis from Northwestern is interesting. They looked at EHR data between, I want to say 2007 and 2018 of 35,000 anesthetics. They identified a GA rate of 5% in Black women and less than 3% in white women. But when they did the sub-analysis, looking just down at the women who entered the OR with a labor epidural catheter in situ, they saw no difference in the incidence of general anesthesia. So we have an opportunity to partner with our patients, with our obstetricians, to really figure out who is most likely to need cesarean delivery and to do shared decision making to help those women consider the benefits of epidural analgesia. But then we also have a responsibility that once we put those epidural catheters in, that we are rounding on the catheters, that we are paying attention to the catheters and ensuring very, very high quality labor analgesia, both because that will improve patient experience and satisfaction for labor, but more importantly, because high-quality labor analgesia is the most important predictor for successful conversion to anesthesia for cesarean delivery. And we know that Black race is among a whole host of risk factors for failed neuraxial anesthesia and pain during cesarean delivery. And I think this will be a topic for later discussion, but I just put it in front of you today that there's evidence that vulnerable populations in particular can have intraoperative pain dismissed and not prevented, and indeed in those cases it's probably most appropriate to go ahead and convert to general anesthesia. And one of the great legacies of APSF is how safe we've made general anesthesia, not just for non-pregnant, but for pregnant people as well. And I think the tools of video laryngoscopy and pulse oximetry, and we're going to talk a little bit about that more in this panel, have been really instrumental in improving the safety of general anesthesia. So I want to move us along and get us to the next speakers. I offer just a few key takeaways that disparities in mortality and severe maternal morbidity are persistent, they're prevalent, but they're highly variable in across health systems, across geographic parts of the country, and it really needs to be addressed at the local level. There are very complex interactions between all these social determinants of health that are far upstream from the clinical encounters. And so when we are taking care of patients, there's recommendations to really take a patient-centered view and to consider each individual patient and all of their complexity and the risk factors that they're bringing forward. With obstetric anesthesia, attention to equitable access to neuraxial analgesia is just the beginning. We really need to focus on the quality of that analgesia and ensuring appropriate use of neuraxial anesthesia for cesarean delivery. I thank you for your attention, and I think, is it Dr. Vaidyanathan is next?
I brought my phone because I can get long-winded. I didn't bring slides, so I can't even use them to keep my time. Is there any way to go back to the last key takeaway slide? Is that possible? I think that's actually what I'd love to speak to. So my name's Mahesh Vaidyanathan. I'm an anesthesiologist at Northwestern. I love doing that, and I get to do it as often as possible, but I spend the rest of my time trying to build technology to help us better care for our patients. And I think where my conversation today is going to fit in is what I was asked by May to do is to instigate some thought, to start the conversation about how do we take the technology that is just coming, or maybe that we already have, glide scopes and other things, and how do we push them into the areas and the spaces around the world and around the country that aren't able to access them? And I think that's really where we can start. I was hoping that the key takeaway slide was still up there, because I can say that one of the key things that Jill talks about is how one county over, the level of care can be significantly different. And why is that? Here in Cook County, a very, very large county, we have disparities of care within the county, and that has to do with resources, resource management. And one of the things I like to talk about is how we can use our technology to expand, to be a force multiplier for those people in this room, to be able to support the care of our maternal population anywhere in the country. One of the things we've done, as an example, at Northwestern is we've made every fetal monitor that's on a patient, visible anywhere in the world. So if one of our obstetricians needs help from one of their colleagues, they don't have to worry about whether they can understand the scenario or the situation. They can say, hey, will you look in room 875 for the last hour and tell me if you think she really needs to go to the operating room or not? She doesn't have to wait for her colleague to figure out what's been going on. They don't need a lot of information. They just need to know what room. They can log in from their cell phone from wherever they are. They can give information to the rest of the team that's on the floor. They can talk directly to the OB residents. But that functionality is not something that needs to be limited to Northwestern. The first question I get asked when someone says, oh, well, you need to have your Philips monitors, and you need to have your OBIX, and you need to have your CareScape backend, you have to have GE, you need to have it set up just like you so that you can see that. And I tell them, no, that's the beauty of the future. We can take data from anywhere, from anything, thanks to companies like the ones I just mentioned, who are changing the way that they present that data so that we can consume it and rapidly reproduce it. And I think that's the future. Right? I think that if I have a question that I need answered and I need May's feedback, I don't need her to be on the phone with me. I can provide data in real time. I can de-identify it, so she doesn't need to know who the patient is. But we can start to spread the knowledge and the care out of our silos, out of our spaces, and into those lower resource areas around the country. Another way that we are trying to do that, I want to give you a non-IT solution, is we worked with a company to start to develop ultrasound scanning using AI in the background to give diagnoses, to give predictions. We're trying to deploy this in a low and middle income country. We're going to publish this pretty soon. But what we were able to do is to take an ultrasound device, scan an abdomen. And by scan abdomen, I don't mean like Dr. Banayan, one of our cardiac specialists at Northwestern, who can give us so much information, very accurately take great pictures and teach our fellows. I'm talking about a nurse who's never scanned an abdomen before to do blind sweeps over the abdomen. They're not looking at the images. They don't care what they get. They're just following the directions of what they need to do. Now, we can get that out into the world. We can do that with cardiac. We can do that with other things. And let the intelligence in the background, let the software in the background do that analysis for us and give us findings. Things like, where's the placenta located? Things like, what do you think the gestational age really is? Is it twins? These are all things that matter, right? When a patient shows up in your L&D and you don't know those things, the first thing you need is an ultrasound. So you need somebody to go grab an ultrasound, somebody who knows what they're looking at to diagnose some of those things, get a medical history at the same time, get access. If some of those things can be shortened, if we can take the burden off of having an expert in the room, but having an expert available, we can start to expand, again, the skills and the knowledge and the technology that we have into these areas that just don't have the resources. Resource direction is, I think, going to be the future of how we expand technology in medicine. And then the last thing I will mention again to get you guys thinking about something that we're working on right now, but I think is going to be the future, is that same technology I talked about before, about being able to visualize our fetal heart rates anywhere in the world. We're actually running that through algorithms. We're building an algorithm to try to predict, currently we're right around 8 to 10 minutes, when a fetal heart rate deceleration is going to happen. So if you can imagine, if your data is part of the larger conglomerate and you're able to have that information provided to you as a notification, if we can do that for every fetal heart rate monitor in the world, in the United States, in all of those limited areas that don't necessarily have access, and we can direct resources to rooms and to mothers that are going to need it before it's recognized. If we can get attention to those rooms before it's too late and now we have to do C-sections instead of being able to resuscitate and prolong that labor. If we can start to modify how we practice and improve outcomes in those days, just based on better data, we'll be able to really start to move the needle on these disparities and these equity issues. The problem and the limitation, which I'll leave you with, is something I think is the reason why I didn't put slides up, because if I put slides up and I show you what our infrastructure looks like, or I show you what our monitors look like, or show you what our software looks like, the first response is always, that's Northwestern, of course. They probably have like a ton of money. They have like 25 engineers. You know, they have all the things they can do that. I can't do that at my institution. We can't get that out into our rural institutions. And what I would like to reassure you is that, again, we are building it in the most open possible way, meaning if you have data, if you've got the device plugged into the wall, we can figure out a way to help you use that data for the benefit of your patients. Limitation, equity. Right now, all that data gets collected locally. So we need to find ways of including those areas in Arkansas, those areas in other parts of the country where the issue is that they aren't getting all that information out, and we need to get it out. And I think that's probably the next step. That's the limitation we need to try to address. And then, of course, the other limitation is knowing the patients, right? We need additional data in more than what is just the fetal heart rate. We need to know what their comorbidities are. Are we treating them for preeclampsia? And one of the things that's coming along that I want to, and I'm just going to put a bug in your guys' ears, the only vocab word that I'll put out there, I want you to ask your friends about it. I want you to look it up on ChatGPT. It's called FHIR, F-H-I-R, okay? That is the future of how we're going to be transmitting healthcare data. If you are in a room making a decision with any leaders in your hospital system, and they ask you, do you think we should invest in this FHIR thing? Say yes, okay? It's expensive in terms of storage space, a little bit of infrastructure, but in the long run, it gives you basically a universal plug. That's the automatic converter if you go to Europe, if you go to Africa, if you go to Canada. I know it's not that far away, but we're SOAP, Montreal next year. But it's the universal converter. So if that's the one thing you take away from the 0 slides, the one vocab I want you to think about is FHIR. It is complicated, but it is beneficial, and that will be the way that we change how we share data around the world. All right. I'm going to hand it off to, who's next? Oh, great.
Thank you, I appreciate it. If I've not had the chance to meet you, my name is Michael Mestick, and I lead clinical research and medical science for Medtronic's acute care and monitoring business. My colleagues and I are incredibly excited to be here with you. We attend the Stoelting conference every year, and it's actually highly competitive to be able to get a ticket. And so we're honored to be here and to participate and to collaborate. And really what we want to talk about today is the role of equitable monitoring in helping you close maternal health care gaps. We think we have something to offer, and I'm going to speak from an industry perspective and tell you about what we're up to, and I think more importantly, how you can collaborate with us to reach our collective goals. I don't know how to advance this. Does anyone know? Here we go. All right, so from an industry perspective, just like you with your case studies clinically, we take a look at problems from a big picture lens first, and then try to drill down to what's going on at the individual patient level. So when we look at something like maternal mortality, always on a personal perspective, like so many have said already today, I'm stunned that we're in this position. It's shocking that we are here in the most advanced healthcare system in the entire world, and this problem is quite real. So we understand that, and as disheartening as those statistics can be, we also understand that the vast majority of this is preventable. And that's where we decide to direct our resources, where we see a big picture problem impacting you as providers impacting patients, and we think that there's something we have to contribute to that problem. So then from there, we start to move from high-level abstract statistics and drill down to get an understanding as to how we can contribute for an individual patient. And as we've already heard many times today, the problem here that we have for women in this country is exacerbated when they are Black women. So there is this healthcare disparity that we see, and so we put a lot of time into considering what might be a representative patient. And in Medtronic, we've actually gone a step further and in many parts started talking directly to the patient to understand what their experience is and what their interaction with our technologies look like. And so as a side note, I grew up right here in this area, and so when I thought about it, I realized that I know one maternal health patient very well. And so if you happen to find yourself in conversation with a retired elementary school principal, that's my mom, and she's joined us here today for the conversation. So she took the train down and wanted to hear what we're doing, you know? And so I'm excited about that, and thank you for attending. So when we look at a patient like Clarissa, we know that our technology, as has already been mentioned, if we focus on pulse oximetry specifically, is going to be a ubiquitous tool throughout that patient's journey. And that can start in the emergency department. And we hear conversations talking about how we need to make sure that a patient doesn't have an oxygen saturation, let's say below 95, I heard, or we'll start screening for heart failure. So these numbers get really specific. 94 is different than 92, and the action that you're going to take. So obviously that means that our technology needs to work. It needs to be accurate on this patient right away as the patient enters the healthcare system. And we're hearing so much about C-sections, we know that intraoperatively there can be complications as well. And for a tool like pulse oximetry, we often think about the SpO2 value, but we also want to consider here the pulse rate for both the mother and the child, and also for the more sophisticated providers, the photoplethysmographic waveform and how that might be dampened in certain situations representing hemodynamic instability. And so we need to make sure that all of these components are working for all patients. And of course, that suite of vital signs is going to be a part of decisions to ultimately transfer the patient and then discharge them home to get to that successful outcome that everyone is looking for. So we're considering this now, and next year we'll certainly be at the conference as well and be talking a little bit more about how we're extending from that acute care setting and moving from hospital to home through a platform that we call HealthCast. So there'll be much more to come on that in subsequent meetings. So with that as a backdrop, I want to take you through some of the things that we've done. So 2 items that I want to cover. First, I want to talk about what we have accomplished over the last 5 years. So I want to talk about our commitment, but I also want to talk about a bit of a progress report on where we are, and then again, invite you to participate with us in the different things that we're doing. So my team spends a lot of time working on the literature, as you can imagine, just trying to summarize what's going on. And so post-COVID, as you're all well aware, there have been quite a few studies looking at how skin pigmentation impacts the performance of pulse oximeters. I think those can be summed up by this representative study in this ANA infographic. So this is based on work out of UCSF, looking at dark skin pigmentation bias, particularly in low perfusion states. So they really wanted to identify this when it matters to you clinically. And the take home is really down in that 3rd row, where if we look at this and say, well, what is the frequency of a misdiagnosis of hypoxemia across the spectrum of skin pigmentations, we see that it's virtually non-existent, about 1%. When patients have light skin, and that ranges all the way to over 20% for patients who have dark skin. So obviously this has clinical consequences that have been well described. And our technology, Nellcor, has been on the market for over 40 years. We're extremely proud of how it performs and that we're a leading technology in the market. But at the same time, when we see something like this, an internal rallying cry for us became, we can do better. We can make a commitment here and we can improve the performance of our technology to make sure that we're working on all patients that you're treating. So we're looking at that from an SpO2 perspective, but then also, again, recognizing that we need to make sure that the performance of our pulse rate in this context of labor and delivery is accurate as well. So this is a study that was published not too long ago. It's independent from Medtronic. But we're looking and saying, you know, the requirements in this case are going to be a pulse rate where you get the signal right away on all of the newborns. We certainly need to make sure that, that's something that you're getting, that it's comparable to an ECG in this environment, that we're not providing you with false positives for things like bradycardia that would interfere with proper care. So we're looking at this from a very holistic perspective and making sure that we get this technology right for you. And what we're finding, not just through published literature, but through our interactions, whether they be at conferences like this or when we're visiting in your hospitals, is that inequity with respect to pulse oximetry is not occurring from just one factor alone. What we're seeing is that there are a variety of SpO2 factors that are adding up, and subtle changes in them seems to be resulting in inequity. So those are things like the base performance of the technology that we're working on, but also things that require education. Still, even though this is a standard of care technology, we see that sensor selection, sensor patient placement is also extremely important here, in addition to things like the perfusion state or skin pigmentation. So these are all things that we're working on, and really it is our vision to empower you, the healthcare providers, with these best-in-class tools that are going to help you personalize care for every single patient, anytime, anywhere. This is not a slide that I made for this presentation. This is something that we present to internal and external audiences. It represents truly what we're about and what we're striving to do every single day. And you can see down in that third row that equitable care is a big part of our vision going forward. And we're doing pretty well, in fact, here. When you think about the tools that have been mentioned today, whether they be pulse oximetry or some of our airway management tools as well, collectively, that being us as the manufacturer, you as clinicians, our technologies are touching the lives of over 115 million patients around the world. And that's impressive to us, it's motivating to us, but obviously that also leaves room for improvement. There are more patients and more places that need our help, and that's what we're striving to do going forward. And so I want to give you some insight as to how we're thinking about this. I'm going to focus on pulse oximetry in particular, but this applies to so many topics that are relevant to APSF members, like brain health would be another good example. But with respect to pulse ox, I said that we can do better on this, and so I want to show you where we've started on this. Certainly that started with education, and many of you have participated in that. So education, not just to clinicians. What's been extremely important to us as Medtronic is getting out into the community. So we've gotten out into the community and started discussing challenges with respect to skin pigmentation. And the reason that we're doing that, and we're doing that fairly specifically in Denver, Colorado, is we started our own clinical physiology research laboratory that we're running there so that we can test the performance of our current devices as well as collect data that will be used to improve our future devices. And so this laboratory is off and running. I certainly don't envy folks like Dr. Main who have 5 minutes to establish trust with a patient. This has taken us years. It's taken us years to go into the community, to talk about the research that we want to do and why. But when patients understand what they're contributing to, we find that they themselves are extremely motivated because they want technologies that will work on people like them in the future. So to date, we've enrolled over 300 subjects in invasive hypoxia studies in our laboratory, and we have a wonderful breakdown across the Monk skin tone scale. We could break it down into tertiles. We can break it down evenly across sexes. And so we're doing very well in terms of representation, and where that's going to lead us is to innovation in technology that is going to help reduce inequities. And so we're just on the cusp of some really exciting things that are going to be coming your way relatively soon. All right. And What I want to do now is truly invite you to participate in this. And so that partnership is what is going to fuel the progress. And so, as I mentioned, it really does start with education. So my colleagues have put together this slide with a QR code on it. That's going to link you specifically to all of the materials that we have around equitable monitoring. So I invite you to take a look. There's a variety of things on there that are both accredited and non-accredited. So take a look. This is for you to consume. This is for you to critique. This is for you to help us take it to the next level. And so there's a lot of materials there. We would love your engagement, and we work with folks like yourselves in a variety of different ways educationally. So I'll invite you to reach out on that on the first front. And throughout the calls, there's been several calls throughout the day already for increased amounts of research on this. And certainly with what's going on from a federal funding standpoint, we consider ourselves to be a very viable research partner at this point. And we can do that in a few different ways. At Medtronic, we call this an external research program. Sometimes that's considered to be investigator-initiated, maybe investigator-sponsored, but this is where you can write a research protocol that aligns with that vision. That's all we ask, that it aligns with the vision and the direction you're hearing me speak about right now. If it does, we have a review panel, and we can provide different levels of support for research studies. That can be financial. Fully recognize that not everyone is comfortable with that from an industry perspective, so there's other ways that we can collaborate as well. Perhaps you just need devices, or you need sensing technologies, whatever that may be. And it's possible the most important thing that we can offer you is some of our expertise. You can imagine doing these types of research studies, the data acquisition for the volumes of data you could collect during a patient's stay can be overwhelming. How do you parse those data? How do you statistically analyze those data? That's somewhere where we can collaborate, and we can help you get these research studies done in quite a few ways. So please do reach out if you have interest there. And then finally, I know several people in this room have actually been to our Denver laboratory, but I would invite you to come visit at any point in time that you want to, whether you be on the clinical side or if you are from another company. We've developed and invested in expertise in the testing for pulse oximeters. We're going to be expanding that to other research devices, and we'd love to talk to you about how we can collaborate and how we can get this done going forward. And so that really is the spirit of what we want to do, invite you to collaborate on education, on research, on testing of these devices to make sure that we're achieving a common goal. And what's great about working for Medtronic is that for over 75 years at this point, everything I've said leading up to now is completely in line with the mission that drives this company. And really it comes down to these 6 words for us. We want to work with you to alleviate pain, restore health, and extend life. That's our mission. We want to partner with you to achieve it. So thank you for your time, and please do reach out. We'd love to hear from you going forward.
All right, I'm bringing up the rear. And we changed the order on you. May and I were reflecting on the panel, and I'm going to talk to you a little bit about implementation science, but I realized it would be helpful to contextualize implementation science after you heard the comments from our wonderful speakers. So I have 2 slides for you. They'll come up momentarily. This is the question I have for you that I want to answer. What is implementation science, and why does it matter for maternal care and outcomes? And I teach implementation science. I've taught a certificate program and all sorts of courses, and I can tell you it confuses a lot of people. How many of you have heard of the phrase implementation science? It's a lot of people by now. How many of you feel like you have a good handle on what it is? Many fewer hands, right? So I'm not going to lecture at you about what it is, but I want to give you a 3 to 5 minute primer on implementation science, and then I'm actually going to invite our panelists up, and I'm going to ask them questions that are relevant to implementation science. And the reason it matters is that, as Elliott mentioned, we have a last mile problem. We know what we ought to be doing to improve maternal health. We have so many examples of seeing that work done well, and yet we still struggle to implement, to see these interventions actually deployed at the level of patient care to improve outcomes at the bedside. So implementation science is all about that last mile and figuring out how to bridge evidence to practice gaps. So the one thing I want to share with you is the implementation science subway, which is a sort of shorthand way of thinking about implementation science that I developed with some colleagues. And I'm going to walk you through what this subway is. We developed it as an accessible way to sort of get people into understanding what this is. There's a QR code in the lower left corner. If you want to scan that, you'll have access to the paper, which is open access. So what we're doing in implementation science is we're trying to bridge evidence to practice gaps. We know what we ought to do, and we know that we don't do it. So how do we bridge that? So the first thing we have people do is to identify their practice of interest. Classically, it's something that has strong evidence. What we've learned in maternal health is that for many reasons that were elucidated already, the quality of the evidence we have is a little dicey. So we do what we can, we identify the practices that we think have promise, and then we move forward. And the first stop on the subway, hopefully many of you have taken a metro or a subway, so this looks a little bit familiar. The first stop on the subway is we ask ourselves, has the practice of interest shown efficacy? In an ideal setting, it could be a randomized controlled trial, it could be a lab study. From a mechanistic perspective, does it work? Does giving people IV iron who are anemic improve their hemoglobin? Yeah, that works, right? That works. There are other interventions where we're not sure if it works. So if we don't know if it works, we actually have to do that. We do efficacy research. That's not implementation science. We want people to design for implementation. I guess I'm done. No. We want people to think about implementation as they're designing their interventions. And this has been one of the topics of discussion that I've had with some of our industry partners as we've talked, is think about that from the inception. So an example I give, if you think about antibiotics, let's say you're going to design a new antibiotic. Don't design an antibiotic that needs to be delivered 6 times a day, because we're not going to do it right. Don't design a technology that is so complicated that it completely disrupts workflow, no one's going to use it. So as you design your interventions, you want to think about implementation, but that's not implementation science. So let's say you have a practice of interest that has in fact shown efficacy. We know that at a mechanistic level it works. The next stop on the subway is to ask ourselves, has it shown effectiveness? So in the real world, with all of the alarms and the multiple patients you're taking care of and all of the things that are going on, does it still work? And if we don't know, then you can do effectiveness research, and we're used to seeing that. Increasingly, we see people look at implementation and effectiveness at the same time. So we're asking questions. We think it'll work, but let's look to see whether it works, but also let's ask ourselves how to get people to do the thing. And so that's what you'll see in that rib that says no or partial, where we're doing trials that include outcomes related to effectiveness, like morbidity and mortality, but we're also looking at implementation outcomes, like are people doing it? How much does it cost? What are the things that get in the way of people doing it? But sometimes we know for sure that it works in the real world, and we're still not doing it. And that's where we thrive as implementation scientists. Like, why aren't people washing their hands? We know that hand washing works. Semmelweis did that work a long, long time ago, right? But people still aren't washing their hands. Then we want to know, what are the contextual factors that influence whether people are adhering to the evidence-based practice? We design implementation strategies to get them to do it, and then we test those implementation strategies. So everything in the lower right corner is implementation science. It's a behavioral science that helps us understand how to get people and places and institutions to do the things that we want them to do. So that's the primer. I'm going to ask our speakers to come up, and then I'm going to give you some questions. I've warned them, they're very softball questions, and I'm going to pepper in some learning about implementation science as we do it. So we'll leave this slide up. Come on up, folks. All right, so before we start, I want to say there were some takeaways that I had from the remarks that I think are relevant to implementation science. Jill, you talked about the power of disaggregating data to understand performance gaps, and you talked about a lot of things that were great, but one of the things I want to highlight is that implementation gaps happen differently across different populations, and I thought you showed that really powerfully, where you showed national data, state level data, and then even regional data to try to understand what's going on. And I especially appreciated that you pulled apart severe maternal morbidity with and without transfusion. And it's those types of manipulations of data that we need to do to dive in on performance gaps, so I appreciate your bringing it up. Mahesh, you talked about variability in institutional resources and the need for interoperable systems and fire, right? As an approach to making data interpretable. But as we're thinking about that last mile piece, we have to think about the structural resources that we need to actually make implementation possible. So I appreciate your bringing that up. Michael, you talked about starting at a high level in terms of thinking about population trends, but always staying grounded in patient stories. And that's something we think about a lot in implementation science, is centering the experience of patients and communities that are afflicted by or affected by the things that we're interested in. So I appreciate your bringing that up. In addition, talking about partnership and collaboration across communities, healthcare providers, institutions, and industry. So my first question, in implementation science, we talk a lot about stakeholder engagement. It's a foundational part of what we do. Our teams are big because they include people that touch our phenomena of interest from many different perspectives. So I'm gonna start with Jill. Who do you think about inviting to the table in efforts to improve maternal outcomes?
It really depends. It depends on the intervention or the outcome that we're trying to impact and the scale at which we're trying to have efficacy. And I think building stakeholder teams is a group effort, and we always invite everybody we can think of and then ask everybody at the table who's missing. And there's always more folks to roll in. And I think especially the maternal AIM bundles, for example, are often hospital-wide implementation tools. And so you need not just clinicians at the table, but you need IT professionals to help build in some of the IT tools. And you need things like blood bank and pharmacy to deliver supplies and medications to the bedside. And so the answer to that is that the team is always bigger than you think of at first.
I think that's great, thank you. And the idea that you ask yourself who's not in the room, I've heard that described as an equity pause, and it's a really powerful tool where you stop and you think, who isn't here that touches this, whose perspective needs to be represented?
And frequently, it's really great to think of if we can get patient representation to solutions, we will often come up with really important gaps that would not otherwise be addressed.
That's great. So as a follow-on, when you think about patient representation, how do you approach that? Because that's tricky, right? I've used patient and family advisory councils. There are sometimes pre-existing relationships, but if you had to give advice to the clinicians in the crowd about actually engaging patients in this work, where might you tell them to start?
I think having a office that focuses on patient and family-centered care is important for developing those relationships, both with patients who have good experiences in your health system, as well as patients who potentially suffer harm. And the tendency is to avoid cases where harm has incurred, but I think there's opportunity for growth, and there are going to be people who are interested in working with the health system to make sure that it's safer for the next family. Those people don't come along every day, and so when they do, it's important to cultivate those relationships.
Thanks. And I should say to our other panelists, if you have something else you want to say, please feel free. So implementation science often focuses on implementing a specific practice of interest. It's that POI in the upper left corner there. There's an implementation scientist named Jeff Curran who's actually in Arkansas at UAMS, and he calls the practice of interest the thing. So the thing that we're trying to do is the practice of interest. If you all could only pick one thing relevant to maternal health, Mahesh, I'll start with you. One thing, what's your thing that you want to focus on?
I think I mentioned it earlier, but and it's been mentioned a few times and it'll be continued mentioned till the end of the time, but the cesarean instance, or the frequency of a cesarean and how we come to that decision is so complicated that if there was technology, if there was a way for us to better predict who is going to need a C-section, who is going to need that attention. I think I was talking to somebody earlier about this, but when we talk about bad outcomes or bad experiences and how that can play a role in how we practice medicine, being able to predict somebody is going to have an adverse event, not even adverse event, an adverse experience would be a place that I would want to change or want to focus on most is trying to predict that and trying to at least, if not, we can't prevent everything, but if we can obfuscate it or prepare ourselves and the patient for the outcome, that'd be beneficial.
Great. Oh, here.
I think that the thing for us is not necessarily different with respect to maternal health, but it is implementation in and of itself. If I go back to your first question, the stakeholder that we've traditionally been focused on is obviously the clinical group. Increasingly, we have to include IT, generally speaking, if you will, because what we're finding is that as monitoring technologies get more sophisticated, you can make them and you can drop them off, but no one will be utilizing them if you don't fit into that hospital ecosystem. And so that's become increasingly important, is that's the aspect of design we've got to get right. There's a stakeholder, a decision maker, and if we don't do that well, what we find is that we can sell a technology a single time. It doesn't benefit you, the clinician, and it never ends up on a patient. And so the whole thing is a stop and a miss if we don't get that aspect of it right. And since I have this, one more comment on your question around around patients. I mean, at Medtronic, as I mentioned, we're doing more patient advisory boards, and some aspects of our business lend themselves better to that than others. But by engaging patients directly, they're helping to shape research protocols, for example, and address things that might not be pragmatic in studies, and the FDA is listening. When we said we got this advice directly from a patient, that's now an allowable justification in many ways. So that's working very well. I think what we need collectively here, as we start talking to patients about risk and about the types of risks that we're trying to help clinicians avoid, what we don't want to do is become a pharma TV commercial where we're sending a message to patients and then they're bringing it to you separately. We want to work together with you and bring that message to the patients together. So I think that's going to be a big part of our interactions going forward, that we want to test that out with you and make sure that we're working together on that front.
I think the one thing I'd like to add to that commentary about implementation in terms of who's in the room is a plug for nerds like me. A lot of you in this room are chairs and leaders in your departments, and identifying one individual that knows what you actually do in the operating room, on the labor and delivery floor, and in the hospital, who can also communicate clearly with the engineers and the IT teams and the industry partners that are coming in to say, I know what you're trying to accomplish. This is how this actually works. Let's try to bridge this gap before you put something out on the floor for your colleagues to use is so critical. And so identifying a few people within the department that are, we've been pulling back and away from that responsibility of the innovation at the bedside. We've been leaning into, we need to be in the operating rooms, right? We don't need to be doing administrative things. We don't need to be doing financial things. We don't need to be doing these other things. We need to be focusing on taking care of patients in the operating room. But when you can identify an individual that's able to bridge that gap, it is, again, a force multiplier for your entire department to be able to provide better care for your patients.
I can think of 3 things, but you asked for one. So I'll say the thing that links to these 2 answers, and that is that, and to Emily Naum's presentation, that really getting the early warning systems in place is a very broad undertaking where you have clear triggers that the nurses who are doing the surveillance on the units are able to point to changes in the vital signs, and they know how that then leads to their next change in terms of increasing monitoring, frequency, and surveillance. And so you have a well-oiled machine that then leads to early recognition of deterioration.
Wonderful, thank you. So let's get even more specific and talk about implementation strategies. So implementation strategies are the interventions that we use that can be applied to individuals, teams, institutions, and communities to bridge evidence to practice gaps. So I mentioned Jeff Curran before. He talks about the thing. He calls implementation strategies the stuff we do to get people to do the thing. He likes simple language because it's very accessible. So earlier today we heard about strategies like patient education, so using advocacy phrases or educating patients on neuraxial anesthesia. We heard about peer-reviewed publications. That's a strategy to improve knowledge, although it is limited because not everyone reads those papers we write. We heard about team training. We heard about building relationships between institutions. There was a question asker from New Jersey who talked about the relationship between her hospital and another one. And we heard about policy-level interventions like the Joint Commission standards that Elliott Main talked about. So for our panelists, I'd love for you to share what strategies you've either used or seen that you think hold particular promise in improving maternal health.
Well, I think the quality care collaboratives that have built up over various states have been successful in creating coaching models to have kind of centers that are further along on the implementation journey partner with centers that are less far along in order to troubleshoot the challenges that they are encountering in terms of implementation, as well as convening those groups regularly to debrief on success stories and opportunities, and then getting data infrastructure across those different centers around the state and analyzing that data at a state level to drive forward change. I think those are all really important examples that our perinatal quality collaboratives have given us.
Yeah, I think the next, the current horizon is availability of information. And I think, I see Heather over here, the most recent past president of SOAP, has done an amazing job of trying to restructure the way we get information out. I think the hardest thing to do is to have the right information in the right place at the right time. And if we can do a better job of having the right data and the right information facing forward, readily available, like the quality collaboratives and other opportunities, that's going to be the thing that drives how our junior practitioners practice.
I think from our perspective, there are a couple things. With the collaborative care model that you all have in this teamwork, we need to make sure that we're providing education to everyone. And folks that we may traditionally have not have, it could be an anesthesia tech or otherwise. But now that information is so readily available, that's actually easier to do. I think the other thing we have to do from an industry perspective is make sure that we're fitting into the day-to-day workflow. It can be hard for folks to take time out to do big, long trainings and things like that. So we've had folks say, hey, that's a great QR code. Could you put that on the side of your monitor and make it really quick so I can take a look at this in real time? Because people are very honest with us. We're not going to read your user manual and try to figure this out from that. So what we want to do is provide that quick real-time information to a broad set of stakeholders to make sure that everyone's on the same page, and then make ourselves more available on an ad hoc basis so as challenges arise, we're answering the questions in real time.
All right, I have one more question for you, but I'm going to invite people to come to the mics in case you have questions. And we're going to try to finish by 12:20 because we have a brief announcement for you before lunch. So technology and technologic solutions have come up repeatedly as possible strategies to improve maternal health. At the same time, there are important considerations to manage conflicts and intellectual property and availability and cost. So people might think about technology but sort of struggle to figure out how to do anything with that idea. So for the clinicians in the crowd and watching online who are going to be returning to their institutions, what key takeaways would you offer them about technology in this space, in the maternal health space, that you want folks to remember? It looks like Mahesh has something to say.
Well, it's very similar to the question I got asked on our panel, which is how do we acquire the resources to do the things that we want to do? You know, how do we do the things? How do we have the things to do the things, I guess? And I think it starts with identifying, sadly, the return on investment. For us, the return on investment is the health of our patients, the success of their care, and their prolonged and lovely lives. But every single one of these interventions that we talk about, every single one of these implementations needs to also be driven by an opportunity. I think one of the opportunities that was presented today that we have utilized in the past is partnering with industry teammates to try and build that opportunity where the institution doesn't feel the burden. That has helped. But the other thing is really identifying those C-suite partners and reassuring them that not only is labor and delivery the most risky place in your hospital, but it could be the safest place in the hospital if you invest in technology and supporting us take care of our mothers.
Yeah, and as a department chair in a resource-constrained institution, I can say they're looking for return on investment. They're looking for cost savings. They're looking for us to save money on Sigamidex use in order to justify getting quantitative train of 4 as an example. And so I think this will get to be increasingly challenging.
I think what I would say is, from an industry perspective, the person who's bringing you that technology, I can almost guarantee, is prepared to help you with that economic value proposition. So it's another area for thought partnership to sit down and say, hey, we have this collective goal. Technology can be part of the solution. Ask them to help you create that economic argument, and then they can prepare you for those discussions. And you can talk through that together. I would say that. And the other thing I would say, technology, the exciting part of this is when we talk about 115 million patients, you can imagine that the most of those are going to be in developed areas, are going to be in more towards urban centers. But I think technology can help us with some of the rural places. It can help us with some of the more remote places. And so I think that technology has the opportunity to partly provide your level of expertise in other areas if we do this right. And so I think there's some excitement there.
I'm so glad that you brought up the possible reach of technology, and I think it sort of brings us full circle to thinking about disparities and looking at ways to narrow those gaps. And so I appreciate your bringing that up. All right, we've got some questions. Steve, go ahead. The light just came on.
Oh, how about now? All right. All right, thank you. Great session, first of all of you. Michael, you might remember me, I don't know, Steve Barker. We've talked. I'm a professor emeritus, retired from the University of Arizona. I've been an academic all my life, but I've also been involved with industry. First, I'll start by saying I am no longer involved with any private industry, none whatsoever. So I'm neutral as of now. And I just wanted to point out that in your, in your discussion of racial effects on pulse oximetry, you've got to be a little careful because one size does not fit all. I published a paper in 2022 in Journal of Clinical Monitoring, and I found in the laboratory comparing accuracies of different pulse oximeters in black subjects and white subjects, and of course, there's a continuous range in between, but we tried to categorize. The different manufacturers perform differently, and of course the reason is they use different secret technologies for processing their signals and compensating for signal strength changes. Obviously, with a very dark black subject, you get less light that comes through for a given light source intensity, and so you have to do some kind of adjustment for that. Anyway, make a long story short, different pulse oximeters from different manufacturers perform differently regarding ratio accuracy, and that's that's kind of a general principle we have to keep in mind, because what's inside the black box is not the same in A versus B, and we, the users, may not even know what's inside the black box because they keep it a secret. I don't blame them for keeping it a secret. It's how you protect IP and keep the Chinese from copying your products. But yeah, it's a fact of life. So it's not one size fits all. What do you say to that?
So I'll say first, thank you for bringing that up. I'm curious what you would say to equip our clinicians who are looking at different types of technologies or different manufacturers, and how do you actually think about what might be the best for your patients?
Yeah, absolutely. I think it's a wonderful point, and certainly didn't want to use our time to get into proprietary differences here. And so, but I can appreciate that, and I think a great resource for the audience. I hope you're familiar with the testing that's being done. I mentioned UCSF, and what they've done in putting together an open oximetry collaborative. I think maybe the largest, most comprehensive data set to allow you to evaluate the differences amongst all of the manufacturers is very simple. If you go to openoximetry.org, Dr. Mike Lipnick and his team out there have put together a great set of resources where you can evaluate the performance of different pulse oximeters, and you can do that in various states. You can look at skin pigmentation as a factor. You can also look at perfusion states. And so I think that's a wonderful resource that's relatively, that's neutral from any one manufacturer that you could go take a look at.
I'm actually going to borrow a note from your playbook. And I think you can ask the companies to help you too, right? So how does your device perform in relation to others? Help me understand why, we're looking at this one. So lots of ways to think about that. All right, let's go to the next question.
Hi, my name is Macy. I'm an anesthesiologist assistant student from Case Western Reserve. And actually, I have kind of a caveat to this question because it was very similar. But so kind of going off of this chart too, after you kind of talk about the efficacy research of how you're going to go about to combat this issue that's currently occurring in most pulse oximetry, that is now 21% in people with darker skin tones not being as accurate. How would you implement, use the scientific implementation to make this usable when you inevitably fix the problem? How are you going to, because like he said, it's not going to fit, just one size doesn't fit all. So what's the plan, I guess, to telling providers and clinicians hey, you should use this science for these people and this science for these people to get the best results?
That's a good question. So anesthesiologists and anesthesia care providers could talk about pulse oximeters forever. So for the OBGYNs in the crowd, I'm really sorry. So I will point out that the inaccuracy in the Bickler paper that showed the 21% bias, it was an interaction between skin tone and perfusion. So it's not 21% inaccurate across the board, but it's that cross. I have been part of discussions that have been really difficult in thinking through this ubiquitous technology that has unmasked potentially some inequities in care, but it also has saved so many lives. And I never practiced in the time where you looked over the drape and you saw the color of the blood and said, oh, I think they're well oxygenated. So I don't want to go back to that, right? So we don't want to throw the baby out with the bathwater, so to speak. But we can think about ways to mitigate that risk. And so part of what I've done and have partnered with other people to do is education in part. It's not the strongest strategy, but to help people understand the circumstances under which the technology works and when it doesn't. So part of it's about critical thinking. And when I teach residents, when I teach fellows, I say that's just a number, but you need to know what's behind the number. You need to know if the perfusion's adequate, if that plethysmograph looks good. Like, you have to know how to use all of the tools. So that's my answer, but I'm sure there's some more over here.
To the presentation this morning by Jennifer Banayan, that that range of pulse oximetry less than 94% being so critical for screening for congestive heart failure is an illustration of the context where accurate measurement is just really, really important.
I'll say, on a brighter note, I'll tell you, I think most of us are familiar in here that GFR used to be calculated differently for different races, and that was changed not too long ago, actually. We figured out that we were making a mistake, and the way that was identified was actually through a large algorithmic model. So a ton of data from Johns Hopkins and some other areas that around the NIH was fed into a model, and it was the predictive model suggested that we were doing it wrong. And I think that's the future. I think that's the answer to your question, is a lot more data provided to the people that are building the black boxes that allows the information, when we talk about, just really quickly, we talk about those frequencies being different. It's the power, the absorption, all these other things that are building up to how that model reads the information and then provides you a number. The more data that model has, the better it performs. And so the better we can get at sharing our data effectively will make our devices and the data that we get back from our patients in real time better.
So with that phenomenal answer in this panel, I'm going to thank you. I'll draw us to a close. We have at the APSF a trainee quality improvement program that we're really proud of. It's part of our effort to build capacity in the field. And I want to turn things over to Brian Camerata, who's going to highlight some of the winners in that program and bring them up to the stage. So this slide can come down, we can take a seat, and Brian, the floor is yours.
You know, there's tremendous social pressure when I'm the person between all of you and lunch. So we're going to keep this moving along. Thank you. My name is Brian Camerata. I have the honor of chairing the APSF Trainee Quality Improvement and Patient Safety Subcommittee. I do want to start by thanking APSF leadership for their ongoing support of this important program, and also recognize subcommittee members, most of whom are at that table over there, for their tireless work throughout the year. They put in a lot of hours to make this program happen. So briefly, in 2015, APSF introduced the annual Trainee Quality Improvement Program. The program has tracks for physician anesthesiology residents, student and resident CRNAs, and student AAs. The program is uniquely designed to identify the best anesthesia-related patient safety work on a national basis. Following a brief COVID hiatus, we reintroduced the program last year and got a great response. Interestingly, we got an even better response this year and have identified winners in all three tracks. I am going to introduce each of the winners and would ask that you hold your applause just kind of for a little bit until I can get everyone introduced. So in the physician anesthesiology resident track, the winning submission was authored by Dr. Ann-Lee Parciola and her associates. And Dr. Parciola, if you would stand. There she is. Dr. Parciola recently completed a fellowship at the University of Virginia. Her project is entitled The Importance of a Standardized Pre-Block Timeout Process, a Quality Improvement Project. In the nurse anesthesia student and resident track, the winning submission was authored by Janice So. Ms. So, if you would, and Janice's mom is there too. She came down. Ms. So is a SRNA at Northeastern University. Her project is entitled Objective Measurement of Endotracheal Cuff Pressures Improves Patient Outcomes, Expert Reviewed Practice Consideration. And then last but certainly not least, in the student anesthesia assistant track, the winning submission was authored by Macy Uhrig. And Ms. Uhrig, if you would. Ms. Uhrig is currently a student AA at Case Western Reserve University. Her project is entitled A Call for Colors, Standardizing drug vial safety, something that has been discussed at a recent Stoelting conference, so very timely. All of the winning submissions are available on the APSF website. I invite all of you to take a look. You can download them. In addition, as you can see, all of our winners are attending the conference, so if you have any questions about their projects, please discuss it with them, and they would be more than happy to address their really important work. So on behalf of Dr. Cole and the subcommittee, we do congratulate all of our winners. We appreciate their commitment not only to the specialty of anesthesiology, but to patient safety, which is why we are all here. In closing, the TQI subcommittee is preparing for the 2026 program, and as been said up here earlier, a lot of you are leaders in the anesthesiology field. We want every trainee in the country to be involved with this program, so please get your students, get your residents. We want everybody in this program. If you go to the APSF website in early January, we will have updated instructions and the very easy submission process, so please encourage your folks to be a part of the 2026 program. And with that, thank you for your time. I think we're having lunch.